Hello everyone, this is Dr. Govindra Garg, or you say Koga sir. So video is regarding the rapid revision. As the name says, it is really rapid. So my suggestion will be you need to study the main videos first, listen to the main videos first, then come to the rapid revision, because here I will be covering most of the facts and little bit of the mechanisms, but I will not go into too much detail about understanding of the topics. Okay, so we will directly start. Our topic is pharmacology. You know, pharmacology is a science dealing with the drugs. Now, before going to the drugs, as a physician, almost all of you or even surgeon, you need to write a prescription. So, first we need to know important points regarding the prescription. Prescription is a written order by a doctor to the pharmacist. Remember, it is not to the patient, it is to the pharmacist to dispense a medicine. Okay. Now, prescription, what is important is, apart from the main things, here the doctor's particulars are written, like name of the doctor, registration number of the doctor, the address of the doctor. Then the patient's information is given, name, age, sex, registration number, all the details are written along with the date also. Now, the most important thing next will be diagnosis. So, this will be the disease, whatever disease it is. Now, after all this, till now the prescription has not started. Now, the prescription is going to start, which starts with the symbol RJ. Remember, it is not X, it is J which is crossing the R, and this is known as superscription. R means recipe, that means you take. J is a Jupiter, which is sign of healing, learning and knowledge. This is God. Okay, so RJ is superscription. Now the drug starts. Like suppose we are writing a prescription of any drug. Suppose we are writing a prescription of tablet alprazolam. Tablet alprazolam 0.5 mg at bedtime, oral, daily for 7 days. Suppose this is the prescription. So this part is known as inscription, and it contains all the detail about the drug, the formulation, tablet, capsule, injection, name of the drug. The important thing is, name of the drug should never be abbreviated. Never write paracetamol as PCM. So that is a wrong prescription. Then the dose of the drug. Now, what is important is dose, like here 0.5 mg is there. What is important? Number one, do not write 0.5, because if point is not read, the person will get 5 mg, which is 10 times. So, before 0 must be written. But trial 0 should never be written. Like if the dose is 5 mg, never write 5.0 mg. It may look like 50 mg. Similarly, do not write microgram as this symbol, because if you don't have that much good handwriting as most doctors have, this may be read as milligram. Clear? So do not write microgram as this. Write either complete microgram or mcg. Okay? So these things need to be kept in mind while writing the dose. Then at bedtime. So we have to give it at the bedtime, and important again, do not abbreviate, do not write the abbreviations. Like commonly for bedtime we write HS. For daily we write OD, for twice a day we write BD. Although the meaning is same, but do not write abbreviations, write complete at bedtime. Then route of administration, orally and daily for 7 days. So that becomes the complete prescription, including inscription, which is the direction to pharmacist, and this also includes subscription, which is direction to the patient how to take the drug. Then comes the signature of the doctor, which is called as initials. Clear? So that is the important things about the prescription. Okay, so that is important. Nowadays questions are being asked on prescription. So now we will go to the pharmacology as such. We know pharmacology is a science dealing with the drugs. When we give drug to a person, it will exert some effect on person's body, and in return person's body will exert some effect on the drug. So these are the two main branches of pharmacology, which are known as pharmacokinetics and pharmacodynamics. Pharmacokinetic is effect of body on the drug. So what happened to the drug is pharmacokinetics, and effect of drug on the body is pharmacodynamics. So pharmacokinetic is the effect of body on the drug. So what happened to the drug? So this is studied under 4 headings called as ADME study, because it deals with 4 important factors: absorption, distribution, metabolism and excretion of drugs. So starting with absorption parameter. So when we give a drug orally, suppose we are giving a drug orally and we want the drug to reach the blood. So we have given a drug orally, it come into the GIT, from air it has to go to the blood. So this arrow means absorption. Movement of drug from site of administration to blood is called as absorption. Okay. Now absorption depend upon lipid solubility. If a drug is lipid soluble, it can easily cross the membrane. Now what is important to remember, when the medium is same, the drug can cross. What is the meaning of this is, if a drug is acidic, it will cross in acidic medium. Because it is lipid soluble in acidic medium, so it is non-ionized, so it can cross. On the other hand, a basic drug, it will cross in basic medium. Because it is lipid soluble, non-ionized, it can cross. In opposite medium, it cannot cross. That means acidic drug cannot cross in basic medium, and basic drug cannot cross in acidic medium, because in opposite medium the drug become water soluble because it has become ionized. So ionized form cannot cross the membranes. So that is important. A drug can cross, absorption is more important when the drug can cross, and the drug can cross in same medium. So that means acidic drugs like aspirin, they can be easily absorbed from stomach. On the other hand, basic drugs like morphine, remember any drug which end with ene is a basic drug. Morphine, atropine, tuberculin. So basic drugs are absorbed from the intestine because the medium is alkaline. But practically every drug, whether it is acidic or basic, they are absorbed more from the intestine. The reason being, intestine has large surface area. So there is plenty of time the drug stays in the intestine, and it has large surface area. So gradually the drug is absorbed from the intestine. So practically every drug, even acidic drugs, are absorbed from intestine more as compared to stomach. Second, the diseases of the intestine which decrease the transit time, like if a person is having diarrhea, so the drug will quickly go through the intestine, so less time for absorption, so that can decrease the absorption. Okay. Now coming to next thing, we have given a drug orally. Suppose we have given 100 molecules orally. First of all, they will reach the liver through the portal circulation. So some of the drug is not absorbed. Suppose 20 molecules are not absorbed. So 80% absorption is there. It reached the liver. But out of the 80%, some molecules will be metabolized in the liver. Suppose 30 are broken in the liver. So only 50 molecule will reach the systemic circulation. So this percentage which reach the systemic circulation, out of 100, only 50% has reached. This is known as bioavailability. Bioavailability, it is the percentage of given dose that reach the systemic circulation. So it depend upon two major factors. One, how much drug is absorbed. More absorption, more bioavailability. Second, how much drug is metabolized here. This is known as first pass metabolism. So more first pass metabolism means lesser bioavailability. Okay. Now regarding the bioavailability, we need to know about a very important graph called as plasma concentration time graph. So we plot a graph between plasma concentration and time. We have given a drug and then we plot the plasma concentration of the drug after every fixed time. So we will get a graph that is called plasma concentration time graph. Suppose this is the graph. So in this graph, we obtain three important parameters. The top point, if we extend it on the y-axis, it is called as Cmax, whereas the same point on the x-axis is called as Tmax. So Cmax is the maximum plasma concentration we will obtain with that particular dose, whereas Tmax is the time in which we obtain that maximum plasma concentration. So what is important? Tmax tells in how much time the plasma concentration become maximum. So what it is telling? Yes. So Tmax is signifying the rate of drug absorption. Rate of drug absorption, how quickly the drug is absorbed. If Tmax is lower, means the drug is absorbed quickly. On the other hand, this total area, this is known as area under the curve. Area under the curve. Area under the curve tells the total how much drug has come into the blood. That means it is telling the extent of drug absorption. Extent of drug absorption. So sometimes the question is asked that a particular drug, suppose drug A has 100 area under the curve. There may be some particular units. 100 is the unit, 100 area under the curve. But when we combine this with another drug B, the area under the curve for A become 150. So what does this mean? This means that B has increased the availability of A in the blood. So that is possible if it is inhibiting the first pass metabolism of A. So first pass metabolism of A has reduced. So more drug has come into blood. So AUC increases. Okay. So that is important about the plasma concentration time graph. Remember, Tmax tells rate of absorption and AUC tell extent of drug absorption. So this is important about absorption. Then after absorption, the drug will be distributed. It will go into different parts of the body. So that distribution is measured by a parameter known as volume of distribution, called as VD, and the formula of VD is amount of drug given by intravenous route divided by plasma concentration obtained. Now on which factor VD will depend? Obviously the volume of distribution or simply distribution will depend upon lipid solubility. A more lipid soluble drug can quickly cross the membranes, it can go to more places, so more distribution. So VD is telling about distribution. Second, it depends upon plasma protein binding. If a drug is bound to proteins in the plasma, remember proteins cannot cross the membranes. The drug will not be able to cross the membrane. So it will stay in the plasma. So that will decrease the volume of distribution. So more plasma protein binding means less distribution. Less plasma protein binding means more distribution. And plasma protein binding, you can remember two type of drugs. We have acidic drugs and we have basic drugs. Acidic drugs usually bind to albumin. Acidic drugs usually bind to albumin, whereas basic drugs usually bind to alpha-1 acid glycoprotein. So plasma protein binding, if it is more, there will be less distribution. And third, it will depend upon presence of barriers like blood-brain barrier. If a drug can cross the barrier, it obviously will have more distribution. Now important thing, what does distribution means or VD means? If a drug has higher VD, means more drug is in the tissues. So higher VD tells that most of the drug is in the tissues, less is in the plasma. Okay. Now what is the clinical importance of volume of distribution? Volume of distribution help us to measure a dose called as loading dose, and the formula of loading dose you can remember as volume of distribution multiplied by target plasma concentration. So loading dose is the initial high dose given to attain a particular plasma concentration. So after attaining, we want to maintain that. So that dose is known as maintenance dose. So that is measured by clearance into target plasma concentration. Okay. So that is loading and maintenance dose. So importance about distribution. Then after distribution, the third important parameter comes, which is called as metabolism or biotransformation. So the main purpose of biotransformation is convert the drug into water soluble so that it can be easily excreted from the body. Now metabolism, we have two main types of reactions, phase 1 reactions and phase 2 reactions. Phase 1 are mostly catabolic reactions like oxidation, reduction, hydrolysis, cyclization, deamination. So these reactions are phase 1. Here the drug is metabolized and become inactive. Whereas phase 2 are conjugation reactions. Here the drug will combine with some substance. So they are better known as conjugation reactions or synthetic reactions. So drug can combine with substances like glucuronide conjugation. It can combine with glutathione conjugation. It can combine with acetyl, methyl, sulfate, any of the group. When it combines with something, it becomes phase 2 reaction. Okay. Now among phase 1, most common phase 1 reaction is oxidation, whereas most common phase 2 reaction is glucuronide conjugation. Purpose of phase 1 reaction is to make the drug sticky, or we can say to attach the conjugation group, or we can say functional group. So when functional group is attached, the drug becomes sticky. Now we can carry out phase 2 reaction. So purpose of phase 2 is to make a drug water soluble. Purpose of phase 1 is to attach the conjugation group or functional group to the drug. Okay. Now all the reaction, whether they are phase 1 or phase 2, they are catalyzed by enzymes. And we have two type of enzymes, microsomal and non-microsomal. So microsomal enzymes are those which are present in the endoplasmic reticulum and they can be induced or inhibited, where non-microsomal enzymes cannot be induced, they cannot be inhibited, means they do not change the number of amount with the other drugs. So if we give another drug, their level do not change. So if we give enzyme inducer, that will increase the metabolism of a drug, so the drug will become inactive very quickly. If we give enzyme inhibitor, that will stop the metabolism, so the drug will become more in concentration, that can lead to toxicity. Okay, so you need to remember the importance enzyme inducers and important enzyme inhibitors. Important enzyme inducers you can remember as GPRS cell phone, GPRS cell phone. G stand for griseofulvin. P is phenytoin. R is rifampicin. S is smoking. C is carbamazepine. And phone is phenobarbital. These are enzyme inducers. They increase the metabolism, drug become inactive. Whereas important enzyme inhibitors include vitamin K, cannot cause enzyme inhibition. So these drugs you can remember as V stand for valproate, K is ketoconazole, C is cimetidine, C is ciprofloxacin, E is erythromycin. Not only erythromycin, some other macrolides also like clarithromycin, roxithromycin. But remember, azithromycin is not enzyme inhibitor. Then INH stand for isoniazid. So these are important enzyme inhibitors. So they can lead to drug interactions. Okay. Now, one of the most important microsomal enzymes is known as CYP enzymes or cytochrome P450 enzymes. So you need to remember the important drugs metabolized by these enzymes. So one of the isoform of CYP is CYP3A4, which metabolizes maximum number of drugs. So drugs metabolized by CYP3A4 you can remember as CT scan. The drugs include C for cyclosporine, T for tacrolimus. These are immunosuppressant drugs. S for statins. Most of these statins are metabolized by CYP3A4. Then on C we have three drugs. We remember them as CAT drugs that stand for cisaparide, estamizole and terfenadine. So CAT drugs, all these drugs, they are metabolized by CYP3A4. And if we give them with enzyme inhibitors like erythromycin, they can lead to drug interactions. The most important, erythromycin like drugs, they will inhibit their metabolism, that will lead to toxicity. And what they do in toxicity, they cause QT prolongation, which can lead to an arrhythmia called torsades de pointes. And you can remember this fact as CAT is cute. So CAT drugs cause QT prolongation. Okay. Then A for amiodarone, and N for navirs. Any drug ending with the navir like ritonavir, emprinavir, these are protease inhibitors of HIV. Okay. So these are the drugs which are metabolized by CYP3A4. Then another important microsomal enzyme is CYP2D6, and from the name you can remember 2 is the second letter, that means B means beta blocker, A is first, B is second. Then D means depression, the drugs which are used for treatment of depression. Most of the drugs like tricyclic antidepressants, we have SSRIs, SNRIs, they are metabolized by CYP2D6. And 6, if you see 6 look like sex, and whenever we talk about sex we got palpitations. So palpitation you can remember as antiarrhythmic drugs. So most of the antiarrhythmic drugs except amiodarone, which we discussed already in CYP3A4. Now next important microsomal enzyme is CYP2C9. So CYP2C9 you can remember C for clotting. So the drug which is used in clotting, very commonly we use, that is warfarin. So anticoagulant, that is metabolized by 2C9. Then another important is CYP2C19. So from the name you can remember C19, C1 look like Cl means clopidogrel. So clopidogrel, it is metabolized by 2C19. What is important, clopidogrel is a prodrug. It become inactive with the help of CYP2C19. So if we give enzyme inhibitors like omeprazole is inhibitor of CYP2C19, so that will stop the metabolism of clopidogrel. So that means clopidogrel will not become active. Remember, CYP2C19 is involved in activation, not in inhibition of clopidogrel. It activates clopidogrel. So if we give omeprazole, clopidogrel will not become active, so it become ineffective. Okay. So further, there are some genetic situations in which a person is having lesser level of CYP2C19. In those people, clopidogrel is not effective. Okay. So these are the important microsomal enzymes. So after metabolism, the last parameter in ADME is excretion. So most of the drugs are excreted by kidney, but some drugs like lithium, it can be excreted in significant amount in saliva and sweat. lithium can be excreted, but most of the drugs are excreted by kidney, and in the kidney the most important we know is glomerular filtration. So drugs are filtered across the glomerulus. Drugs are filtered. So important thing is every drug, whether it's lipid soluble or water soluble, can be filtered by glomerulus. So there is no barrier to glomerular filtration. Only important problem here is plasma protein binding. If a drug has more plasma protein binding, it cannot be filtered. Now after filtration, most of the drug is reabsorbed. So tubular reabsorption. But important thing is, unlike glomerulus in which there are fenestrations or we can say pores, all the drugs can be filtered, but reabsorption will occur only with the lipid soluble drug because the tubular membrane is complete. So reabsorption required lipid soluble drug. Water soluble drug cannot be reabsorbed. So now important thing is we can utilize this property if we make a drug water soluble inside the tubules. Remember, if we change the medium to opposite, the drug become water soluble, so it cannot be reabsorbed. So we can utilize this principle in drug poisoning, like in case of aspirin poisoning. We know aspirin is an acidic drug. In case of poisoning, we will want to excrete aspirin. So if we make the urine basic, the medium opposite. The drug is acidic, medium is basic, so it cannot cross the membrane, means it cannot come back, so it will be excreted out. So in case of acidic drug poisoning like aspirin, we give sodium bicarbonate, make the urine alkaline, so the drug is excreted. The opposite is done for basic drug. In basic drug poisoning like amphetamine poisoning, we give ammonium chloride that will make the urine acidic, so the drug will be excreted. Okay. Then last parameter in excretion is tubular secretion. Some drugs are excreted by the secretion through the tubules, and this is very important in case of probe and acid. Remember that the secretion process is saturable, that means only one drug can be secreted at one time. Penicillins, when we give, penicillins are quickly secreted, so they are very short acting. But if we give penicillin and probenecid together, probenecid is also secreted by same pump, but it has higher affinity. So penicillin cannot be secreted, so they remain in the blood. So plasma concentration of penicillin increase, they become long acting. So probenecid make the penicillins long acting by inhibiting the tubular secretion. Okay. So these are the four parameters of pharmacokinetics, A, D, M, E. Now related to these parameters, we have some formulas. The most important being half-life. Half-life is the time in which plasma concentration of a drug become half, 50%. The formula of half-life is 0.693 into volume of distribution divided by clearance. Now actually this thing, volume of distribution by clearance, if we make it opposite, clearance divided by volume of distribution, this is known as elimination rate constant or K. Clear? So if we write it here, the formula of half-life become 0.693 divided by K. So sometime the value of K is given, then you can calculate the half-life of the drug. Okay. Now based on all these parameters, we have order of kinetics. The drugs follow two type of kinetics, first order and zero order kinetics. So you can remember everything from the first letter of first order kinetics. In first order kinetic, fraction of a drug excreted is constant. That means in unit time, same percentage will be excreted. Whereas in zero order, the amount is fixed. In unit time, same amount will be excreted. So that will create the differences between these two. In first order kinetics, rate of elimination is proportional to plasma concentration, whereas it is constant in zero order kinetics. Whereas half-life and clearance, they are constant in first order kinetics, but they are not constant in zero order kinetics. Okay. In simple terms, if we see in first order kinetics, if we double the dose, the plasma concentration become double. Whereas in zero order kinetic, we cannot predict that. So in first order kinetic, with increasing the dose, the concentration become double. With the decreasing the dose to half, the concentration become half. Okay. But half-life and clearance remain constant in first order kinetics. Okay. So with that, we completed the pharmacokinetics. Now moving to pharmacodynamics. Effect of drug on the bodies. So drugs mainly act by two mechanisms, either through enzymes or through receptors. So first of all, talking about enzyme inhibitors. The drug inhibiting the enzymes, they may be competitive inhibitors, that they may be non-competitive inhibitors. The most important thing you need to remember about two parameters, one is Km, second is Vmax. In case of competitive inhibitor, Km increases, whereas in non-competitive, Vmax decreases. The other parameter do not change. So you can simply remember, if there is competition, you need to run more kilometers. So in competitive inhibitors, Km increases, Vmax do not change. In non-competitive, Vmax decreases, Km do not change. Now this thing is plotted sometime in graphical manner. So that plot is known as Lineweaver-Burke plot, or simply known as double reciprocal graph or double reciprocal plot. So what is the meaning of double reciprocal is, we have two axes, x-axis and y-axis. On the x-axis, we have reciprocal of substrate concentration. We have 1 by S, and on the y-axis, we have reciprocal of Vmax, or we can say reaction velocity 1 by V. Clear? So when we plot a graph, it comes like this with a normal drug. So this is with the normal drug. Suppose this is normal without any inhibitor. Now we give inhibitor and we plot the graph again. So we now can calculate whether it is competitive or non-competitive inhibitor. Very simple concept you need to remember. If the graph is intersecting on the y-axis, like suppose the second drug, it is giving a graph like this. The second drug is giving a graph like this. That means this is same, this point is same, so this is with inhibitor. So this point is same, this point is telling about 1 by V. 1 by V means Vmax. So Vmax is constant, only the substrate concentration change, that means Km change. So this is done by, yes, it is done by competitive inhibitor. So competitive inhibitor, the line will intersect at y-axis, whereas in case of non-competitive inhibitor, it will intersect at x-axis. So if the graph is like this, remember the Km is same but Vmax changes, then it is a non-competitive inhibitor. So just you need to see where the graph is intersecting. If it is intersecting on the y-axis, it will be a competitive inhibitor. If it is intersecting on x-axis, it will be a non-competitive inhibitor. Okay. Now second main mechanism of drugs is through receptors. Now what is important is, when a drug binds to the receptor, that is known as affinity, ability of a drug to bind to receptor. And second, after binding, it should produce action. That ability is known as intrinsic activity. Now all the drugs which work through receptors must have good affinity. If affinity is not good, they cannot work. So most of them, we differentiate them based on intrinsic activity. Intrinsic activity may be different in different drugs. So based on intrinsic activity, we divide the drugs into 4 types. They are called as agonist, partial agonist, inverse agonist, and antagonist. So the intrinsic activity of partial agonist, agonist is maximum. Partial agonist name says it is sub-maximum, less than maximum. Inverse agonist, it is negative, and antagonist, it is 0, no intrinsic activity. Okay? So based on intrinsic activity divide, remember they all have high affinity. Now sometimes the graph is also plotted like this. Suppose this is the percentage of activity, receptor activity, and suppose this is 0. In case of agonist, this will be 100%. 100%. So if the graph is like this, it is agonist. It is agonist. If it is 0, that means graph is like this, it is antagonist. Antagonist has no intrinsic activity. So partial agonist will be anywhere in between the two. It is partial agonist. And inverse agonist is inverse, that means negative. So inverse agonist will be below 0. So this is the graph of agonist, antagonist, etc. Now second thing, these drugs, they were working on receptors. Every receptor has some particular signal transduction mechanism. So based on that, we divide the receptors into 4 types. Receptors are 4 types. Number 1 is ionotropic receptors. These are present on the ion channels. So when the drug binds to the receptor, the ion channel open, the ions move, the action comes. So these are fastest acting receptors. Fastest acting receptors. So these are present at important places. These are present in the CNS. Mainly in the CNS, the receptors for GABA A and receptors of glutamate, that means NMDA, they are ionotropic receptors. Second, they are present at junction of the nerve and muscle. So nicotinic receptor NN and NM are ionotropic. And third type you need to remember is 5-HT3. These are ionotropic receptors and these are fastest acting receptors. Then second type of receptors are known as enzymatic receptors. So again, very simple mechanism. This is the cell, this is the receptor. So drug bind outside, it will activate the receptor, that will activate an enzyme inside the cell. So that will do the work. Mostly this enzyme is tyrosine kinase. So these are also known as tyrosine kinase receptors. And these receptors, these are remembered as receptors for pig hormones. That is prolactin, receptors of prolactin, insulin, and growth hormone are enzymatic receptors. Apart from this, the receptors of cytokines, all these cytokines like interleukins, tumor necrosis factor, they are also enzymatic receptors. Okay. Then third type of receptors are intracellular receptors. Intracellular means they are inside the cell. So they may be intracytoplasmic, they may be intranuclear. How these receptors work, most important thing is drug must be lipid soluble to enter inside the cell. So only lipid soluble drug can work on these receptors. So after the drug penetrates the cell, it will bind to the receptor, whether it is in the cytoplasm or nucleus. Then it will enter the nucleus and bind to DNA. So they act by affecting the DNA replication, transcription, translation. So these are very slow acting drugs. And the drugs which work on intracytoplasmic receptors are remembered as CD. So these are receptors for corticosteroids. That means glucocorticoids and mineralocorticoids. And D means receptors of vitamin D. Whereas intranuclear receptors are remembered as SAT, SAT. So sex hormone receptors, most of the sex hormones, estrogen, progesterone, testosterone, they work on nuclear receptors. But testosterone are present partly in the nucleus, partly in the cytoplasm also. A for vitamin A and T for thyroid hormones. The receptors of these are intranuclear. Okay. Then lastly, we have G protein coupled receptors. G protein coupled receptors. Here the simple mechanism is the drug will bind to the receptor. This is the receptor, drug binds. Then it will activate a G protein which will break into two components. One is inactive, second is active. That will produce the action, and mostly the action is either by changing the level of cyclic AMP, increasing or decreasing cyclic AMP, or changing the level of calcium. Now we have different type of G proteins to produce these actions. The important G proteins are, you need to remember, are GS, GI and GQ. GS will stimulate an enzyme called as adenylate cyclase. When this enzyme is stimulated, it will increase cyclic AMP. Whereas GI will inhibit adenylate cyclase. So that will decrease cyclic AMP. And GQ receptors, G proteins, what they will do is they will activate an enzyme called as phospholipase that will break down phosphatidyl inositol bisphosphate to IP3 and diacylglycerol, and these will increase calcium. So you can remember Q for calcium. Q work through calcium. Yeah. So these are the four type of receptors through which the drugs work. Okay. Next important concept in pharmacodynamics is a dose response curve. If you see, dose response curve may be of two types. It may be graded, it may be quantal. So if you see, if on the y-axis there is a response, not percentage, it is a response, how much response, 0%, 1%, 10%, 100%, not the number of people, and on the x-axis there is dose of the drug. So if we plot a graph, it will become hyperbola. Shape of DRC is hyperbola. But if we change the dose into logarithmic form, convert into logarithmic form, that is known as log DRC. So that DRC is sigmoid in shape. Okay. So remember, DRC is hyperbola, but log DRC is sigmoid. So clinically we always use log DRC, and from the log DRC we obtain three important parameters. One is potency, second is efficacy, and third is slope. So potency, it tells that how strong a drug is. That means lesser dose required to produce the same action, the stronger the drug is or more potent the drug is. So potency, you can see it is told by left or right on the DRC. So if we see, this is log dose, this is response, this is one drug, this is second drug, A and B. So A is more potent because it is on left side, because it requires lesser dose. Okay. Then coming to efficacy means maximum response. So efficacy simply is known from the height of the graph. So if there is log dose and response graph, one drug is producing effect like this and second drug is producing effect like this. So this drug is more efficacious. So higher and lower tell about efficacy, left and right tell about potency. Then third is slope. Slope tell about safety of a drug. As for slope, as for safety, if a drug is more steep, suddenly the graph rises, means the drug is unsafe, because slight increase in dose can produce significant increase in response that can lead to toxicity. Okay. Then second are the quantal DRC. Quantal DRC, as the name tells, on the y-axis there will be quantity, not percentage. On the y-axis there is percentage of subjects responding. So on the x-axis there is dose and on the y-axis percentage of subjects responding. So if you see the 50%, that means at what dose 50% of the subjects respond, that dose is known as ED50. ED50 means effective dose in 50% of the patients. If we on the y-axis we take how many percentage of animals die. So if we see at what dose 50% of the animals die, that dose is known as LD50, lethal dose in 50%. And if we divide the two, LD50 divided by ED50, this is known as therapeutic index of the drug. And remember, therapeutic index you can remember as style. Therapeutic index is LD50 by ED50 and therapeutic index tells about margin of safety of a drug. That means higher the therapeutic index, more safer the drug is. Okay. So that is about the dose response curve. So after the dose response curve, we need to discuss very important parameter known as clinical trials. So there are many drugs in the market. There must be tight regulation for them. There is a regulatory authority in America that is known as FDA. US FDA, Food and Drug Administration. In India, that authority is known as DCGI, which works under Central Drug Standard Control Organization. DCGI stands for Drug Controller General of India. Okay. Now, in clinical trials, there are different phases. First, the drug is tested in the animals. If the drug is found to be good, it is tested in humans. So, it is tested in 4 phases, phase 1, 2, 3, 4. Phase 1 trials are done in healthy people. Because they are healthy, we cannot test the efficacy. So, they are mainly for the knowing the dose of a drug. Because we are first time giving the drug to a person. So, phase 1 is known we measure the maximum tolerable dose. The main criteria is this. So we monitor the safety at what dose maximum safe effect we can get. Then phase 2 trials are done in patients. These are first trial for efficacy. Small number of patients are taken, around 20, 30, 100, 500, up to 500 patients we enroll. Small number of patients. We test the efficacy for the first time. Side by side we test the safety. But phase 1 and 2 cannot confirm efficacy. So phase 3 is also done in patients, but large number, up to 5,000 of patients we take, and here we confirm efficacy. So read very carefully. In phase 2 we first time test efficacy, phase 3 we confirm efficacy, and phase 4 is after marketing. So after phase 3 the drug will come into market. Still the trials are done which are called as post marketing studies. So that is phase 4. So these are mainly done for rare and long term side effects of a drug. Maximum number of subjects are recruited in phase 4 because the drug is already in the market. Thousands of people are already taking the drug. Okay. Now in the clinical trial there is a term known as control. So mostly the control can be standard control, we can say drug control, or there can be placebo. So placebo control studies or standard control can be studies. And second, there are randomization. Randomization means every person has equal chance of getting either the drug or the placebo. Okay. So important thing, there are studies which are known as open studies, single blind studies, and double blind studies. Open means everyone knows who is getting the drug, who is getting the placebo. This is usually done in phase 1 when we do not need to test the efficacy. Whereas single blind studies are those in which patient is unaware whether he is getting a drug or placebo, but the investigator knows. So these are usually done in phase 2. Whereas double blind studies in which neither the physician nor the patient knows which person is getting drug and which person is getting placebo. They are known as double blind studies. They are done in phase 3 and they are the best studies so far. That's why phase 3 are randomized controlled double blind studies. Okay. So that is about the clinical trials. The next important thing we need to discuss is about drug label. currently the questions are asked on drug label. So on the drug label, they will give the strip of the drug and ask what is written on that. So on the drug label, first of all, name will be written. Name can be generic name, that means which is the actual name, like aspirin. The name can be chemical name like acetyl salicylic acid, and the name can be brand name like Ecosprin. So out of these three names, the most important is generic name. It must be present on the drug label. Second, there are some abbreviations written on the drug label like IP, BP, USP. So basically, like the name may contain aspirin IP. So what is IP? IP, BP, USP, they stand for pharmacopoeias. So IP is Indian Pharmacopoeia, BP is British Pharmacopoeia, and USP is United States Pharmacopoeia. So these are pharmacopoeias or formularies, which are big books, contain the details about the drug. So it is as a reference, you can find the details here. Okay. Then third important thing on the drug label, what is written is either the drug is OTC or Schedule H. OTC means over the counter drug, that means you do not require prescription, whereas Schedule H drugs are those which require prescription. And for Schedule H drugs, usually a red line is drawn on the drug label so that you can easily identify that this is Schedule H and you can ask for prescription. Then there is written manufacturing date and expiry date of the medicine. And expiry date, you need to remember that expiry date, suppose it is written as June 2022, that means you can use till the last date of June, that means 30th June 2022. Okay. Then difference between expiry date and manufacturing date is known as shelf life. That means how much time the drug can be kept on the shelf of the pharmacist, it can be useful. Okay. Then lastly, we need to know the temperature controls, at which temperature we should store the drug. So the drug can be, it can be written as keep cool, keep cold, and keep frozen. So keep frozen means around minus 20 degrees Celsius, keep cold means 2 to 8 degrees Celsius, and keep cool means at room temperature. These are the storage temperature of the drug. Okay. Similar to drug label, there is a question asked on drug advertisement. Basically a pamphlet which the MR brings to the hospital and asks the doctor to prescribe that drug. So what is important in drug advertisement is it should also contain the name of the drug. Its name can be generic and brand, but brand name should not be more than 3 font sizes than the generic name. Apart from the name, there must be presence of side effects of the drug. Remember, all type of side effects there which are either serious, all serious side effects must be written. But if the side effect is not serious but common, even then it should be written. Only side effect you can skip is which are uncommon and non-serious. Okay. Then there should be complete course of the drug with cost. So you should be able to compare that, how many times you need to give the drug, by which route, all the details about that drug should be there. Then there must be written a reference. If the drug company is making some claim that this is the best drug in the market, then you should get a reference from where you are getting this, that it is the best drug. And apart from the reference, there must be address of the company. If there is anything wrong, where you can apply. What is most important is on the drug advertisement, there is no we can say no requirement of the expiry date. In fact, no meaning of expiry date, because expiry date is for drugs. These are not for the pamphlets. Okay. So that is important about the drug advertisement. Now, according to Drugs and Cosmetics Act, there are some type of drugs explained, like there are spurious drugs, misbranded drugs, and contaminated drugs. Spurious drugs are those drugs in which one pharmaceutical company, which is not a well-known company, a new company, is trying to mimic the product of a well-known reputed company. So that company is trying to take the advantage of a well-known company by keeping the name of the drug very similar to that, or maybe exactly same. So that type of drug is known as spurious drug. Misbranded drug is a name when there is anything wrong written on the drug label, like if the concentration written is wrong, or there is no, the drug is Schedule H but red line is not there, Schedule H warning is not written. These are known as misbranded drugs. Then contaminated drug, the name says these contain some filthy or unhealthy material, like sometime from the tablet a hair is coming out. They ask which type of drug it is contaminated drug. Now there is one term which is known as counterfeit drug. counterfeit drug, it is not a term in the Drugs and Cosmetic Act, but it is used commonly in USA. It covers all type of drugs, all these type of drugs. Counterfeit simply means fake drug. So whenever there is a pharmaceutical company or any person try to fake the drug, it may be containing the name of the other company, or it may be containing different concentrations, no active ingredient at all, it may be contaminated. Everything comes under the counterfeit drug. So in India it is not used. In India these terms are used. Okay, then there is a term known as FDC, called as fixed dose drug combinations. Fixed dose drug combination, simply FDCs. So in this, what we is doing, we are combining two or more drugs together in a fixed ratio. Okay. So first of all, what is the advantage of combining the drugs? The most important advantage will be compliance. The person do not need to take 2 or 3 drugs, they need to take only one drug. But second advantage can be the side effect of one drug may be nullified by the other drug. Side effect may be minimized. Suppose one drug is causing hyperkalemia, second is causing hypokalemia, they will nullify. Then there may be decrease in cost, because we do not need to develop 2 separate drugs. So one drug is containing both, the cost may reduce. Then sometimes the efficacy may increase. One drug may increase the effect of other drug. But what is the disadvantage? The most important disadvantage being the drug may be used irrationally, like ciprofloxacin. It is a fixed dose combination of ciprofloxacin with tinidazole. So if a person is requiring only ciprofloxacin, still we are giving tinidazole in addition. So irrational use is very common. Second, there may be increase in cost. If the person require only one drug, the other drug we are giving unnecessarily, that increase the cost. Similarly, that is contributing to side effect which we do not want. Then most importantly, we cannot vary dose. They are in fixed proportion. If we want to give one drug more higher dose, second lesser dose, we cannot do. Okay? So these are the main advantage and disadvantage of fixed dose combinations. Okay. Now last thing in general pharmacology is drug use in pregnancy. So drugs are categorized into different categories for use in pregnancy. These may be pregnancy category A, B, C, D and X. These are according to safety. A is the safest, B lesser safer, C less, D is still less, and X is totally contraindicated. So drug A are those in which clinical trials in humans have shown that the drug is safe. So the drug is absolutely safe. B, in which clinical trial in animals have shown that the drug is safe, but human trials are lacking. Human trials are not sufficient. Drug C, in which not sufficient evidence is there, but clinical trial in animals, they are showing that the drug is teratogenic. Human trials are not there. Human trials are not there, but the category D, in which clinical trial in humans, they have shown that the drug is teratogenic. But the benefits of the drug, they outweigh the risk to the patient. So still we can use sometimes. But category X are the drugs in which clinical trial in humans show that the drug is teratogenic, and also the risks are much more than the benefits. So they are absolutely contraindicated in pregnancy, like thalidomide. Now another important thing to remember is Schedule X and Category X are different. So these are pregnancy categories. But if we say drug is Schedule X, it means the drug is narcotic drug. Schedule X is narcotic drug like morphine. They are Schedule X drugs. Okay. So these are the different pregnancy categories. Now important to remember about some category of drugs, like drugs for hypertension. Which drugs are safe in pregnancy, which are contraindicated in pregnancy. The important drugs which are safe for hypertension in pregnancy, you need to remember, are two. One is methyl dopa, second is labetalol. They are very safe in pregnancy, but absolutely contraindicated are ACE inhibitors and angiotensin receptor blockers. Second, you need to remember about hyperthyroidism in pregnancy. Hyperthyroidism. The drug safe is propyl thiouracil. Remember, particularly in the first trimester, they ask propyl thiouracil is drug of choice. You can remember propyl thiouracil PTU says पहले trimester में use करना है. Whereas carbimazole like drugs are contraindicated in first trimester. Then we need to see anti-epileptic drugs in pregnancy. Epilepsy in pregnancy, the safest drug being levetiracetam and lamotrigine. Levetiracetam and lamotrigine. Whereas the drug which are contraindicated, absolutely contraindicated, is valproate. We should be, not absolutely, we should avoid as much as possible. The next important are the drug for bipolar disorder in pregnancy. Remember, the safest drug are antipsychotics. Antipsychotics like olanzapine, their drug of choice is pregnancy. Lithium is usually avoided, but if absolutely necessary, we can give. But valproate we should avoid at all costs in bipolar disorder. Okay. Then lastly, antimicrobial agents. Antimicrobial agents. The safe drugs in pregnancy are usually remembered as PCM, penicillin, cephalosporin, macrolides, whereas usually tetracyclines and fluoroquinolones are contraindicated in pregnancy. Okay, so these are the important points regarding the general pharmacology. Our next topic is autonomic nervous system. We know this is mainly divided into two types, sympathetic and parasympathetic. First of all, the basic criteria of dividing into sympathetic and parasympathetic is anatomy. The nerve fibers which originate from thoracolumbar are sympathetic, which originate from craniosacral are parasympathetic. After origin, both of them form connection in the ganglion. In sympathetic system, it is called sympathetic ganglion. In parasympathetic, it is called as parasympathetic ganglion. As the diagram clearly tells, the preganglic neurons in the parasympathetic system are longer, postganglionic are smaller. In case of sympathetic, it is opposite. Then coming to the neurotransmitter at all the preganglionic fibers is acetylcholine, whether it is sympathetic or parasympathetic, and they will stimulate the N receptors, that means nerve and nerve junction, you can remember, and N receptors on the postganglionic neuron. Now second neuron take the information to the organs like in the eye, in the heart and other areas, and inside the organs they again secrete a neurotransmitter which is different in sympathetic and parasympathetic. In sympathetic this is mostly noradrenaline, whereas in parasympathetic it is mostly acetylcholine. So parasympathetic, both the fibers secrete acetylcholine, that is also known as cholinergic, whereas sympathetic mostly is known as adrenergic. But one important exception is sympathetic supplied to sweat gland secrete acetylcholine. So sweat gland supplied by sympathetic system but secrete acetylcholine. Then coming to actions or functions. Functions of sympathetic and parasympathetic, they are mostly opposite. At most of the places they have opposite functions. And you can easily remember, if we talk about heart, we know sympathy is related to heart. So sympathetic system should stimulate the heart, whereas parasympathetic system depress the heart. At all other places make it opposite. That means parasympathetic will stimulate, sympathetic will inhibit. The other means, like in case of bronchus in the lungs, parasympathetic system cause bronchoconstriction, sympathetic cause bronchodilation. In the GIT, parasympathetic stimulate the GIT, leading to more secretions, more movements that can lead to diarrhea, whereas sympathetic overactivity can lead to constipation. In the glands, parasympathetic will increase secretions that cause watery secretions, sympathetic decrease secretions that can lead to thick secretions, except sweating, because it is mediated by acetylcholine. It is increased by sympathetic system. Then in the bladder, parasympathetic system will relax the bladder, decrease urine outflow, sympathetic system will decrease urine outflow. In case of pupil, parasympathetic will stimulate, that means it will cause constriction leading to meiosis. Sympathetic opposite, it will cause mydriasis. So basically the actions are opposite. You can remember, sympathetic system stimulate the heart and inhibit everything else, parasympathetic opposite. Okay. Now we can discuss the system separately, starting with the parasympathetic system. We know the major neurotransmitter in the parasympathetic system is acetylcholine. So how it is produced is, first of all, choline comes from outside, which is a rate limiting step. Then it is converted to acetylcholine, that is stored inside the vesicle. Whenever nerve impulse comes, acetylcholine come in the synapse and start producing the action on the receptors. After some time, it is metabolized with the help of an enzyme called as acetylcholine esterase. So if we inhibit these steps, we can modulate parasympathetic activity. Drug which inhibit the entry of choline inside the neuron, it is known as hemicholinum. The name says that hemi means half, of choline is coming in, hemicholininium. Then second, the drug which inhibit the entry in the vesicle is called as visamicol. Visamicol. So in Hindi you can remember, vesicle में choline आएगा ही नहीं. Then third drug which inhibit the release of acetylcholine is botulinum toxin. Botulinum toxin. It prevents the release of acetylcholine in the synapse. So all three drugs will decrease parasympathetic activity. On the other hand, if we block acetylcholine esterase, it will increase parasympathetic activity because acetylcholine cannot be broken. More acetylcholine, more action. Now all these drugs will finally act on receptors. So these receptors of cholinergic system are of two types. They may be nicotinic, they may be muscarinic. So we have nicotinic and muscarinic receptors of the parasympathetic system. Nicotinic receptors are mainly NN and NM, whereas muscarinic are mainly M1, M2 and M3 receptors. You can easily remember NN nerve and nerve junction, so they are present in ganglia, both sympathetic and parasympathetic. NM is present at neuromuscular junction. Special thing to remember, they require optimal stimulation. Neither less nor more. In both cases, muscle will not work. Whereas an M1 receptor is present on stomach, increase the acid in the stomach. M2 is present in the heart, it inhibit the heart, bradycardia will happen. M3 is present at all other places, including the pupil, the bronchus, GIT, bladder. Everywhere else we have M3 receptors, and we know M3 stimulates. So pupil stimulate meiosis, bronchoconstriction, GIT will be stimulated, diarrhea, bladder stimulated more outflow, gland stimulated more secretions. So you can easily remember, पहले खाओ पियो, फिर दिल लगाओ, बाकी काम बाद में कर लेना. पहले खाओ पियो means M1 in stomach, फिर दिल लगाओ M2 in heart, everywhere else we have M3. Okay. So we have discussed the location and action of different parasympathetic receptors. So now we can discuss the drugs, which we can broadly divide into two types: parasympathomimetic drugs or cholinergic drugs, and later on we will discuss parasympatholytic or anticholinergic drugs. So mimetic drugs, they can be broadly divided into directly acting and indirectly acting. Directly acting, which directly work on receptors. Indirectly acting drug which increase acetylcholine, that will work on receptors. So basically indirectly acting drug is acetylcholinesterase inhibitor. Now directly acting drug, the main drug you need to remember is pilocarpine, and second is bethanicol. Bethanicol, you can remember from the name, it contains col means acetylchol, so acetylcholine, and B means bladder. It is working on bladder. That means it is used mainly for atonic bladder. When bladder is not working, it will stimulate the bladder. Whereas pilocarpine, it is working on P for pupil, so it will cause contraction of pupil, meiosis, that will treat the angle closure glaucoma. So pilocarpine is used as eye drops in angle closure glaucoma. Now coming to indirectly acting drug, acetylcholinesterase inhibitors, they may be reversible, they may be irreversible. Reversible drugs are commonly used clinically, whereas irreversible drugs are usually toxic drugs. So starting with the reversible acetylcholinesterase inhibitors, they may be divided into lipid soluble and water soluble drugs. The main lipid soluble drug in this category is physostigmine. Whereas main water soluble drug is neostigmine. So from the name you can remember, neostigmine is saying that nahi hai soluble. So physostigmine is lipid soluble drug, so it can cross the membranes, so it can enter the eye, so we can use it in glaucoma. So physostigmine is used in angle closure glaucoma. Second thing, physostigmine can enter the brain also, so it is used in atropine poisoning. Physostigmine is drug of choice for atropine poisoning. Now there are other lipid soluble drugs like tacrin, which was drug of choice for Alzheimer's disease. Remember, in Alzheimer's disease, there is a deficiency of acetylcholine in the brain. So when we increase acetylcholine, we can treat Alzheimer's disease. Tacrin was the drug of choice, but it had two problems. One, it was short acting, so need to be given 4 times a day. And second, it was hepatotoxic. So we developed new drugs which did not have these two problems. So they are now the drug of choice. They are donepezil, rivastigmine, and galantamine. These are also lipid soluble acetylcholinesterase inhibitors, but they do not cause hepatotoxicity, or they are not short acting, they are long acting, and they do not cause much side effects. So these are drug of choice for Alzheimer's disease. They increase the memory, and you can remember from my name, they are called as Dr. Govind drugs. Okay, so these are the lipid soluble acetylcholinesterase inhibitors. Coming to water soluble drugs, the water soluble drugs include neostigmine, pyridostigmine, and adrophonium. The main use of these drugs is in the myasthenia gravis. First and the major use is myasthenia gravis. Adrophonium is used for diagnosis of myasthenia gravis. It is very short acting drug. After giving adrophonium, if the condition of the person improves, it is myasthenia. If it is worsen, it is cholinergic crisis. Whereas neostigmine and pyridostigmine are longer acting, they are used for treatment of myasthenia gravis. But whenever we use neostigmine or pyridostigmine, how they work is, neostigmine like drugs, they will increase acetylcholine. That will stimulate both nicotinic and muscarinic receptor. So in myasthenia, we want to stimulate NM, which is good. So it will improve muscle condition, but it will unnecessarily stimulate M1, M2 and M3, which will lead to side effects. So along with this, we give a blocker of M1, M2 and M3, which is atropine. So atropine is commonly combined to neostigmine and pyridostigmine whenever we want action on the NM receptors, like in myasthenia gravis. Okay. Then another important use of these drugs, neostigmine like drugs, is cobra bite. Remember, cobra bite is a neurotoxic snake. So it will cause paralysis of the muscles by blocking the NM receptors. So again, we can use neostigmine plus atropine combination for cobra bite. Okay, so these are the important points regarding the reversible drugs. Now moving to irreversible acetylcholine esterase inhibitors. These are permanently inhibiting the acetylcholine esterase that can lead to toxicity. The important drugs are organophosphates and carbamates. The important organophosphates are malathion and parathion, whereas important carbamates are carbaryl and propoxyl. So these drugs, they cause toxicity in humans, and mostly these cause toxicity in farmers because they are commonly exposed to these drugs. They use them in fields. So when these drugs are given or a person is exposed to these drugs, what will happen? They will inhibit acetylcholine esterase permanently. That will increase acetylcholine. Acetylcholine will stimulate the muscarinic receptors M1, M2 and M3. M1 stimulation will lead to acidity. Remember, it is present in the stomach. M2 stimulation will lead to bradycardia and hypotension. Remember, M2 is in the heart, it is depressing the heart. M3 in the eye will cause pinpoint pupil. Remember, it is causing meiosis. It in the GIT, or we can say everywhere, it will increase the secretions. Gland secretions increase. Then in the GIT, there will be diarrhea. In the bladder, there will be urinary incontinence. There will be bronchoconstriction, respiratory problem. So M3 stimulation cause problem. And in overdose, when all three receptors in the brain are stimulated, person can go to coma. So organophosphate poisoning is very easy to diagnose. The patient usually is a farmer, presented with bradycardia and hypotension on examination. But most important symptoms are pinpoint pupil and increase in secretions. Now another important thing, sometimes the characteristic garlic odor is also present. Garlic odor is also present in organophosphate poisoning. Now all these symptoms are seen, and these can be treated by blocking these. And the drug which block all of them is atropine. So atropine is drug of choice for organophosphate poisoning and carbamate poisoning. But problem is atropine can treat all these symptoms. But atropine itself is very toxic. If we give an overdose, the poisoning is even more dangerous. So we need to gradually keep on giving atropine till all the symptoms subside. So how we will come to know that effective dose of atropine has been given? So that is known by signs of atropinization. The important signs of atropinization, these include mydriasis, that means dilatation of pupil. That includes decrease in secretions and tachycardia. So these are the three main signs. Mydriasis is most commonly used sign of atropinization, whereas decrease in secretion is most reliable sign of atropinization. Okay, so we keep on giving atropine till the patient improve. But in some person, which is practically not possible, theoretically possible, there may be stimulation of nicotinic receptors like NN or NM. If NM receptor is overstimulated, it will lead to muscle weakness. And if NN is stimulated, which is present in the ganglion, it can cause sympathetic overactivity also, like there may be tachycardia, there may be hypertension, which is really very low. Mainly you will always find hypotension and bradycardia. Rare cases you can find this, but if other symptoms like pinpoint pupil and increase in secretions are present, then do not get confused with this. Now the question is asked, atropine can reverse all the symptoms of OP poisoning, except the answer will be these symptoms. So most commonly the answer to this is muscle weakness. Okay. Now apart from atropine, second type of drug we can use are called as oximes. We have pralidoxime, which is known as PAM, and we have diacetyl monooxime. And in the oximes, you need to remember three important points. First and the most important, they are not the drug of choice. Remember, drug of choice is always atropine. Second, you can remember triple O. Triple O means oximes are only for organophosphate poisoning. Oximes are not for carbamate poisoning. And third, the difference between PAM and DAM. PAM, you can remember, P is peripheral. PAM acts only in periphery, not in the brain. DAM, D means दोनों places. DAM दोनों जगह काम करती है, periphery as well as brain. Okay, so that is important about the organophosphate poisoning. Also means we completed the cholinergic drugs. Now moving to anticholinergic or parasympatholytic drugs. So we have three main cholinergic receptors, M1, M2, M3. So anticholinergic drugs may be M1 blocker, they may be M2 blocker, they may be M3 blockers. So M1 blocker, M1 was present in the stomach, increasing the acid. When we block M1, less acid, so we can use in peptic ulcer. So the drug is piranzepam and talanzepam. They are used in peptic ulcer disease. M2 was present in the heart. So when we block M2, heart will be stimulated. Remember, M2 was blocking the heart. So when we block, heart will be stimulated. So they can be used when the heart is depressed, like in AV block, in bradycardia. So we can treat these conditions by giving M2 blocker. So the drug used is atropine. In fact, atropine is a drug of choice for bradycardia and AV block. Then M3 is present at many places. Like M3, if we talk about in the bronchus, M3 was causing bronchoconstriction. If we give a blocker, there will be bronchodilation. So we can use the drug in bronchial asthma. We can use the drug in bronchial asthma, and the drug which we use is ipratropium. Ipratropium. Ipratropium, from the name you can find it is containing atropium. Atropine like drug given by inhalational route. Ipratropium. But in some patient, it has been found that ipratropium, we know that it should cause bronchodilation, but sometimes it causes bronchoconstriction. So that is known as paradoxical bronchoconstriction. Paradoxical bronchoconstriction. So why this happens? To explain this, there may be impurities in the ipratropium which irritate the bronchus, that can cause bronchoconstriction. These impurities may be benzylalkonium, it may be EDTA. These may be the impurities present in ipratropium. Or while giving the nebulization, if we use hypertonic saline, then that can irritate the bronchus, can lead to bronchoconstriction. And third, it is anticholinergic drug. It may block the presynaptic cholinergic receptors, presynaptic muscarinic receptors. So when presynaptic muscarinic receptors are blocked, there may be more release of acetylcholine, and that more acetylcholine can cause bronchoconstriction. So these are the mechanism of paradoxical bronchoconstriction by ipratropium. Now, apart from the bronchus, we have bladder. M3 receptors on the bladder, they are causing contraction of bladder. When we block M3, there will be relaxation of bladder. So we can use these drugs in overactive bladder. Overactive bladder, we can use them. We want to relax the bladder, and these drugs are remembered as soft bladder, solifenacin, oxybutynin, flavoxate, and tolterodine. These will relax the bladder, and DAR means darifenacin. So they are used in overactive bladder. Okay. Then we have drugs which act on the glands. Again, M3 receptor, it causes increase in secretions. When we block M3, there will be decrease in secretion. This we can use in a pre-anesthetic medication. Remember, during anesthesia, we do not want any secretion. So before anesthesia, we give these drugs, and the drug which we use is glycopyrrolate. Glycopyrrolate is used in glands as pre-anesthetic medication, anti-secretory medication. Next important is in the eye. M3 receptor was causing miosis. The blocker of M3 will cause mydriasis. Not only mydriasis, these will also cause loss of the corneal reflex. Not corneal reflex, the loss of the accommodation reflex. Accommodation cannot happen, so that is known as cycloplegia. They cause mydriasis and cycloplegia. We have 4 drugs causing this: atropine, hometropine, cyclopentolate, and tropicamide. Now, atropine, it is very strong cycloplegic drug. So, it is a drug of choice for refraction testing in children. Remember, in a child, there is very strong tone of ciliary muscle. So, we have to use a strong drug, which is atropine, but it is very long acting in the eye. Sometimes the action remains for 7 days. So, it is not preferred in adults. So, in adults, we will prefer tropicamide, which is the shortest acting drug in this category. Okay. So, these are the actions in the eye. Then, most importantly, they are used in poisonings. We just discussed they are drug of choice. Atropine is drug of choice for organophosphate and carbamide poisoning. It is also drug of choice for early mushroom poisoning. Early mushroom poisoning. Okay. Now, apart from the users of these drugs, they can also be toxic. So, if atropine is given in overdose, there may be atropine poisoning. Now, there are some plants from which we obtain atropine. If they are taken, they can lead to poisoning. So, those plants which give rise to atropine are Dhatura stramomia and belladonna. So, Dhatura poisoning, belladonna poisoning, or atropine poisoning are same thing. The main symptoms in these, commonly the question is asked like a child ate we can say wild fruit, and after that these symptoms come. What are the main symptoms? The symptoms are agitation, urinary retention, dryness, and other anticholinergic symptoms will be there, like there will be tachycardia, and cholinergic system depress the heart, there will be tachycardia. So all these symptoms will come, and they will ask which poisoning it is likely, or what is the treatment. What is the treatment of atropine poisoning? Yes, it is physostigmine. Physostigmine is a drug of choice for atropine poisoning. Okay. So that is important about the anticholinergic drugs also. That means we completed the parasympathetic system. Now we will move to sympathetic system. So just like the parasympathetic system, if you see, sympathetic system also, the neurotransmitter is produced and stored here. The neurotransmitter here is mainly noradrenaline. So whenever nerve impulse come, noradrenaline is released, then it will work on the receptors, and after that action has to be stopped, which is done by reuptake. So it goes back, the action stops. So the adrenergic drugs or sympathetic drugs, they may be of 2 types. One which directly work on receptors, and second which inhibit the reuptake. So this is directly acting, this is indirectly acting. And the most important indirectly acting drug which inhibit the reuptake, you need to know, is cocaine. Okay. So we'll move to these sympathetic drugs, or we can say adrenergic drugs. So adrenergic drugs may be directly acting, may be indirectly acting drugs. Directly acting drug is, we are going to discuss in detail. Indirectly acting drug is cocaine. So cocaine we know is a local anesthetic. It's ending with cane, so it is a local anesthetic. All local anesthetic cause vasodilation, but cocaine cause vasoconstriction. CO means constriction, because it is increasing noradrenaline by inhibiting the reuptake, that can cause vasoconstriction. Now, second important thing, cocaine is used in psychiatry. It is an addictive drug. So what is special point about cocaine as addictive drug is it causes tactile hallucinations. Tactile hallucinations, which is also known as cocaine bugs. So person who is addict feels that insects are running on the skin, but actually nothing is there. But when the person feels that insects are running, so they will keep on scratching. So most important symptom in the cocaine addiction is you can see scratch marks, you can see ulcerations on the skin, because the person is constantly scratching that. Clear? So that is one important indication about the cocaine addiction. Second, apart from the cocaine bugs, you can see cocaine is a sympathetic drug. So there will be sympathetic system symptoms, like there will be tachycardia, hypertension. These will be seen. Plus cocaine can cause we can say agitation. Overdose, the person can come with agitation. Agitation will be there. And then in severe overdose, because of extreme sympathetic overactivity, there can be myocardial infarction and even death of the person. Okay? So commonly question asked is which is not seen in cocaine overdose. Usually the answer is bradycardia. It is sympathetic drug, it causes tachycardia. Okay? Then moving to directly acting drugs. So directly acting adrenergic drugs we can divide into catecholamines and non-catecholamines. Catecholamines, the main catecholamines, although we have many more, the main catecholamines are adrenaline, noradrenaline and dopamine. Starting with the dopamine. Dopamine, it acts on three main receptors, D1, beta 1 and alpha 1. These are dose dependent effects. D1 is stimulated at lowest dose less than 2 microgram per kg body weight per minute. But if the dose is increased up to 10, it stimulates beta 1, and at more than 10, it stimulates alpha 1 receptors also. Remember, D1 receptors are mainly present in the kidney that lead to renal vasodilation. So there will be increase in renal blood flow at low dose. At slightly more dose, there will be stimulation of heart. And at very high dose, there will be vasoconstriction that can increase the blood pressure. So dopamine, it is a drug of choice for shock with oligouria. That means when a person is having shock as well as renal failure, we give dopamine at high doses because it causes vasoconstriction that will treat the shock. But at the same time, it is stimulating D1 and increasing the blood flow to kidney and protect the kidney. So dopamine is drug of choice for shock with oligouria. Okay. Then coming to noradrenaline and adrenaline, you can remember A for adrenaline, A for all the receptors. So adrenaline stimulate all the receptor means alpha 1, alpha 2, beta 1 and beta 2. Whereas noradrenaline, not all, it stimulate only 3, alpha 1, alpha 2 and beta 1. So before going to the actions of these, we will quickly discuss about these receptors. So we have alpha 1, alpha 2, beta 1, beta 2 receptors. Alpha 1 receptors you need to remember at three main places. In the blood vessels, it causes vasoconstriction. In the eye, it causes mydriasis. And in the prostatic urethra, it causes constriction of urethra that will lead to decreased urine outflow. Okay. So three important locations of alpha 1 to remember: vasoconstriction, mydriasis and decreased outflow. Whereas alpha 2 is mainly acting as a brake. It is a presynaptic receptor. Whenever we stimulate that, it will decrease the release of noradrenaline. Beta 1 you need to remember only at two places. One is in the heart and second is in the JG cells of kidney. In the heart, it stimulates the heart. In JG cells, it releases renin. Whereas beta 2 is present at most other locations. The important ones you need to remember: beta 2 is present in the bronchus, which causes bronchodilation. Beta 2 is present in the uterus, which will relax the uterus. It is present in the blood vessels where it causes vasodilation. And remember, it is mainly present in the blood vessels of skeletal muscles and blood vessels of coronaries. So it stimulates them, bronchodilation and vasodilation will occur. Beta 2 is also present in the skeletal muscles, which can lead to tremors. Beta 2 is also present in the liver. In the liver, it increases the production of blood sugar, so it reverses hypoglycemia. Okay. So these are the important actions of beta 2. And lastly, beta 3 can be present in the bladder, urinary bladder. It relaxes the bladder. When we stimulate beta 3 by giving a drug called as mirabegron, it is used in overactive bladder. Mirabegron, it will relax the bladder, used for overactive bladder. Okay. So these are the main receptors of sympathetic system. So now we can discuss the uses of adrenaline and noradrenaline. Now noradrenaline, it is primarily used for treatment of shock. In particularly, it is a drug of choice for septic shock. Now what is most important question which is asked is how to assess the effect of noradrenaline in shock, whether it is working or it is not working. It is very simple. Simply check the blood pressure. So if there is increase in mean arterial pressure, means noradrenaline is working. Okay. Then moving to adrenaline, which is the most important drug, adrenaline. Adrenaline is drug of choice for anaphylactic shock. It is drug of choice for anaphylactic shock. It is given in a concentration of 1:1000 by intramuscular. If first dose do not work, then we will repeat. Usually we give 0.5 ml. If first dose do not work, repeat. And if second dose do not work, then in desperate circumstances, we will give 1:10,000 solution of adrenaline by intravenous route. First we try IM. If not working, then we give IV. It is drug of choice for anaphylactic shock. Second, adrenaline is also drug of choice for cardiac arrest. After cardiopulmonary resuscitation is not working, then we will try adrenaline. But for cardiopulmonary resuscitation, we give adrenaline IV as 1:10,000. We give IV. If intravenous access is not available, we can use intraosseous route. Intraosseous route. If this is also not available, we can use endotracheal route. Okay. Then adrenaline is commonly added to local anesthetics. It causes vasoconstriction, prolong the duration of action, and decrease systemic toxicity of local anesthetics. And the concentration used is 1:1 lakh, 1:1 lakh to 1:2 lakh. So highly diluted solution of adrenaline is used. Okay. Then we have a phenomenon called as vasomotor reversal of Dale. Now what happens when we give adrenaline in high dose? So adrenaline stimulates both alpha 1 as well as beta 2 receptors. Alpha 1 cause vasoconstriction, beta cause vasodilation. But alpha 1 receptors are stronger receptors. That means whenever both are stimulated, then main effect will be of alpha 1. But beta 2 is sensitive. That means they can be stimulated even by low dose of adrenaline, whereas alpha 1 cannot be stimulated. So when we give high dose, both the receptors are stimulated. So the blood pressure, it will suddenly shoot because alpha 1 also stimulated, beta 2 also stimulated. So effect of alpha 1 is predominant than beta 2. So that lead to increase in blood pressure. After some time, the metabolism occur and this effect started decreasing. And when they become lower than a sufficient level, then only beta 2 is stimulated, that lead to decrease in BP. So only beta 2, that is causing fall. And after some time, this is metabolized, so effects start returning toward normal and that become normal. So this is normally biphasic response of adrenaline. Two phases, first BP increases, then BP decreases. First increase is due to alpha 1, second decrease is due to beta 2. But if we give adrenaline with alpha blocker, what will happen? This alpha 1 effect will not come. So when we give adrenaline here, we already have given alpha blocker. So there will be only fall and that will be much more than normal. So this exaggerated fall instead of biphasic response is known as vasomotor reversal of Day. Okay. So it is seen in a combination with adrenaline and alpha blocker. Okay. So this is about the catecholamines. So now we will quickly move to non-catecholamine group of sympathomimetic drugs. In the non-catecholamine group, we have alpha 1 agonist, the drug stimulating alpha 1 drug receptors like phenylephrine. Phenylephrine is commonly used as eye drops. It causes mydriasis. Important thing is it causes mydriasis without cycloplegia, only mydriasis. Then we have drug stimulating alpha 2 receptors like clonidine and methyl-dopa. These drugs, they act like a brake. Alpha 2 is a brake. So they decrease the sympathetic activity. So they decrease the blood pressure. So they are used for treatment of hypertension. Then we have drugs like beta 2 agonist. So two main groups. One group is salbutamol group. Salbutamol, terbutaline like drugs. And second we have ritodrine group. Both are beta 2 agonist. Salbutamol is given by inhalational route used for bronchial asthma. Whereas ritodrine is mainly used as a tocolytic drug. It will relax the uterus. Now, salbutamol like drugs, the main side effects you can remember, it causes tremors, tachycardia. So that is in fact common to both salbutamol as well as ritodrine. But salbutamol in addition, it also causes movement of potassium from the blood into the cells. So that can lead to hypokalemia. In ritodrine, one extra side effect is present, which is pulmonary edema. Remember, beta 2 is increasing the blood sugar. We discussed it is present in liver, increased blood sugar. So they will never cause hypoglycemia. Rather, they can cause hyperglycemia, but they will never cause hypoglycemia. That is commonly asked question. Which of the following is not a side effect of beta 2 agonist? The answer will be hypoglycemia. They do not cause hypo, they cause hyperglycemia. Okay. So that is about the catecholamines and non-catecholamines. Now we will move to anti-adrenergic drugs or sympathetic system blocking drugs. We can broadly divide them into alpha blockers and beta blockers. Now alpha blockers, they can be non-selective, that means alpha 1 plus alpha 2 blocker, or they can be selective alpha 1 blockers. Non-selective alpha blocker like phenoxybenzamine or phentolamine They permanently block. Phenoxybenzamin is mainly used in pheochromocytoma, whereas phentolamine is commonly used in cheese reaction and clonidine withdrawal. Okay. On the other hand, alpha-1 blockers, the drugs which end with josin, like prazosin, tirazosin, doxazosin, L-fujosin. These drugs, they are used mainly for treatment of hypertension, and in particular if hypertension is associated with BHP. Remember, alpha-1 which is present in the prostate is causing contraction of urethra. So they are used for hypertension with BHP. But the major side effect of josin group of drugs is they cause postural hypotension, also known as first dose hypotension. So to avoid this side effect, we have developed a drug which is called as tamsulosin, and another drug of this group is silodosin. These drugs are selective alpha-1A blocker. Remember, in the prostate we have alpha-1A, whereas in the blood vessels we have alpha-1B. So these drugs are used in BHP. They will not affect the blood pressure, so lesser chance of causing postural hypertension. But because they are not used in postural hypertension, they will not decrease BP. They are not causing postural hypertension, they are not decreasing BP, so they are not useful in hypertension. Not useful in hypertension or any problem of the blood vessels. Okay. Now, apart from the BHP and hypertension, alpha blockers like prazosin, they are drug of choice for scorpion sting. Scorpion sting, they are drug of choice. They can also be used in peripheral vascular disease like Raynaud disease. But in peripheral vascular disease, drug of choice are calcium channel blockers like Dipin's group of drugs, but these can also be tried. Okay. So that is important about alpha blockers. Now moving to beta blockers. Beta blockers are the drugs ending with lol. There are cardioselective beta blockers which are blocking only beta 1 receptors. They are remembered as new beta blockers act exclusively at myocardium. The drugs in this group include Navivolo, Bitoxolo, Bisoprolo, Acebutolo, Esmolo, Atenolol, Metoprolol, and Celiprolol. So these drugs, they are acting only at myocardium. That means they are working only on heart. They are not used for extracardiac conditions. But that is the advantage also. They are not acting outside the heart, so they do not worsen, or we can say they are relatively safe in conditions outside heart. What are the three main conditions? That is asthma, diabetes, and peripheral vascular disease. These are safe in these patients: asthma, diabetes, and peripheral vascular disease. Okay. Second important property of beta blocker is membrane stabilizing property, or we can say sodium channel blocking property, or we can say local anesthetic property. So these you can remember as possess membrane stabilizing or local anesthetic property activity. Possess membrane stabilizing or local anesthetic activity. P stand for propranolol, metoprolol, levetolol, acebutolol, and so it is active property pindolol. So these are having membrane stabilizing property. The advantage of this property is they are having the membrane stabilizing property, so they are used in arrhythmias. They are good for arrhythmias, but they are contraindicated in glaucoma because they will anesthetize the cornea, which we do not want. The next is intrinsic sympathomimetic activity or partial agonistic activity. Partial agonistic activity. So these drugs are useful when we do not want to block the heart too much. So these drugs remembered as contain partial agonistic activity. Celiprolol, pindolol, alpranolol, and acebutolol. contain partial agonistic activity. They are preferred when the person is developing severe bradycardia with the use of a normal beta blocker. Okay. Next important property is water solubility. Water solubility has the advantage that they cannot enter the brain, so CNS side effects are not there. And second important thing is these drugs are contraindicated in renal failure because kidney mainly excrete water soluble drugs, so they cannot be excreted. That can lead to toxicity. And these drugs you can remember as ANS: atenolol, nadolol, and sotalol. They are contraindicated in renal failure. Okay. So these are the important properties of beta blockers. Now quickly we can discuss the indications of beta blockers. Indications may be cardiac, may be non-cardiac, or we can say extra cardiac. Cardiac users of beta blockers, you can name any disease in the heart, they will be useful, like they are used in hypertension, angina, myocardial infarction, congestive heart failure, arrhythmias. Everywhere in the heart they are useful. Hypertrophic obstructive cardiomyopathy. Extra cardiac users, you can remember them at play the game. Play the game. Performance anxiety. Performance anxiety. Thyroid, hyperthyroidism. Hyperthyroidism. Glaucoma. Timolol is used. Akathisia. Beta blockers are drug of choice for akathisia. Migraine, they are used in prophylaxis of migraine. Propranolol is drug of choice. And essential tremors, beta blockers are used. So beta blockers, they are used in play the game. Then moving to side effects and contraindications. Again, we can divide them into cardiac side effects and non-cardiac side effects. Cardiac side effects you can remember easily. They are depressing the heart, so they can cause bradycardia. They can decrease conduction. They can decrease contractility. So beta blockers, they are contraindicated in bradycardia or conditions like sick sinus syndrome. Contraindicated in AV block, contraindicated in acute CHF. Remember, they are used in chronic but contraindicated in acute CHF. And non-cardiac, we already discussed, they are contraindicated in asthma, diabetes, and peripheral vascular disease. Yeah. So these are the important points regarding the beta blockers also. Now, we need to discuss another important topic which is called glaucoma. Glaucoma is increase in intraocular pressure. And we want to decrease intraocular pressure, so that can be decreased by two methods, either by decreasing the formation of aqueous humor, or we can say secretion of aqueous humor, or by increasing the outflow of aqueous humor. The drug which decrease the formation, they mainly act by causing vasoconstriction because blood is making the aqueous humor. So they can be alpha agonist or they can be beta blocker. Alpha agonist may be non-specific like adrenaline or dipivefrin, or they may be alpha 2 specific like in the eye like clonidine, apraclonidine in particular, apraclonidine and bremonidine. Then beta blockers like timolol, or they can increase the outflow which may be trabecular outflow or uveoscleral outflow. Trabecular outflow is increased by meiotic drugs. By causing meiosis, space becomes that they can remove, and uveoscleral is increased by prostaglandin F2 alpha. Okay. Now coming to side effects of anti-glaucoma drugs, which are very important. So you can remember them like meiotics. Meiotics drugs like pilocarpine, they cause two main side effects. C for cataract. Meiotics, they can induce cataract and they can cause stenosis of nasolacrimal duct. Stenosis of nasolacrimal duct. Then apraclonidine, you can see apraclonidine, the name itself says LID, so it can cause lid retraction. Apraclonidine can cause lid retraction, whereas bremonidine, it can cause brain inhibition. Brain inhibition, particularly in the newborn, it can cause apnea. It is contraindicated in newborn babies because it can cause apnea, depress the brain. Then we have drugs like prostaglandin F2 alpha. The drug mainly used is latanoprost. It is drug of choice for glaucoma, open angle glaucoma. The main side effects are pigmentation of the iris known as heterochromia iridis. Heterochromia iridis. It can cause growth of eyelashes, which is known as hypertrichosis. And it can cause fluid in macula, means it can cause macular edema. But important thing, all of these are local side effects. It do not cause systemic side effects. That's why it is drug of choice for glaucoma. Another important thing, it is a prostaglandin, and prostaglandins can cause inflammation. So it is contraindicated if there is inflammation in the eye. Like if patient is having glaucoma, along with that person is having keratitis. The question may be given like there is cells in the echosumor, there is keratic precipitates they are giving inflammation as the sideways. So if there is inflammation, latanoprost should not be given. Okay. Then lastly, we have a drug called as adrenaline or dapivirine. It can cause pigmentation of conjunctiva. So these are important points regarding the anti-glaucoma drugs. Now lastly, there are two rabbit experiments in the eye. One is in the rabbit eye and second is on the rabbit ileum. So what is done in these experiments? In the rabbit eye, you will instill the unknown drug and you need to identify what it is on the basis of actions. So what are the actions? One, size of the pupil. You need to see size of the pupil, whether there is meiosis or mydriasis. Second, what happened to light reflex. And third, what happened to corneal reflex. Now 4 type of drugs are given. One drug is sympathomimetic drug like adrenal. Second drug is parasympathomimetic drug like acetylcholine, pilocarpine, etc. And third is parasympatholytic drug like atropine. And fourth is local anesthetic like lignocaine. So what will happen? If first of all we will check the corneal reflex. If it is lost, it is done only by local anesthetic. So the answer will be directly local anesthetic. If corneal reflex is present, means it cannot be local anesthetic. Then we will check for the light reflex. So light reflex can be lost by only one drug, that is atropine, anticholinergic drug. If anticholinergic drug is, it is atropine. If light reflex and corneal reflex both are present, so it cannot be atropine, it cannot be local anesthetic, then we will see the size of the pupil. If the size of pupil increase, it is sympathomimetic drug, which cause mydriasis. And if the size of pupil decrease, that means meiosis occur, size decrease, then it is a parasympathomimetic drug like pilocarpine, acetylcholine. Okay, you can easily identify rabbit eye. Then coming to rabbit ileum. In rabbit ileum experiment, you will tie the ileum to the liver and plot a graph by adding different drugs. So you need to identify which type of drug it is. Now second is on the rabbit ileum. So rabbit ileum, again you need to identify unknown drug is added to the tube and you need to check which is the unknown drug. So if you see, this is the normal contractions of the rabbit ileum. When we add the unknown drug, if the graph goes up, that means it is stimulant of ileum. And stimulant of ileum, they give only 2 type options. Either they give calcium chloride or barium chloride. And second, they give acetylcholine. The basic difference is acetylcholine action can be stopped if we block the cholinergic receptors. That means if we give atropine, it cannot stimulate. So after the ileum is stimulated, means we have either one of these 2 options. So what we will do, we will wash and keep back to the normal contractions. And here we will add atropine. And when we add atropine and again we add the unknown drug, if the graph still rises, that means it cannot be acetylcholine. So answer will be calcium or barium chloride. But if the graph do not rise and it comes like this, then it will be acetylcholine. Easy. Similarly, this is unknown normal contractions. We give unknown drug and the graph falls. So that means it is depressant of ileum. And depressant of ileum again are given 2 types. One is given adrenaline and second is given papaverine. So that means adrenaline and papaverine can depress, but adrenaline action we can block. So that means after washing, taking normal contraction, if we give beta blocker, adrenaline mainly act through beta receptors. So again give the unknown drug. If the contraction do not fall further, that means action has been stopped. The answer will be adrenaline. But if the contraction still become low, the answer is papaverine. Okay? So it is that easy as that. Sometimes they do not give the detail, they simply give this is the normal contraction and after giving unknown, the graph falls. And only adrenaline is in the option, papaverine is not, then adrenaline will be the answer. Okay. So that is important about the rabbit experiments also. That means we have completed the autonomic nervous system. Okay. The next topic we are going to discuss is autocoids. So we all know these are the substances which have autocrine effects, means local effects. The important autocoids being histamine, serotonin and prostaglandins. So discussing these one by one. Histamine act through various receptors H1, 2, 3 and 4. H1, it is responsible for causing allergy, but useful action is it promote wakefulness, it keeps us awake. H2 secrete acid in the stomach. That's why H2 blockers like cimetidine and ranitidine are used in peptic ulcer. H3 receptors, they are presynaptic autoreceptors. They inhibit the release of histamine. So if we block H3, histamine will be released more, and that can result in promotion of wakefulness. That means we can use the drug in narcolepsy. And H4 causes chemotaxis. The most important drug will be drugs which block H1 receptors. So they are called as H1 antihistaminics or simply antihistaminics. They are divided into first and second generation drugs. The basic difference between the first and second generation antihistaminics is first generation can cross the blood-brain barrier. So they will block H1 in the brain leading to sedation, whereas second generation do not cause sedation or minimal sedation. First generation have additional anticholinergic property, whereas second generation do not. So because of anticholinergic property, they can cause anticholinergic side effects like dryness, blurring of vision, etc. But they have anticholinergic users also. So first generation have extra users. What are those extra users apart from allergy? Remember, both first and second generation are used in allergy, but the first generation have extra users which you can remember as possess anticholinergic property. First generation drugs possess anticholinergic property. So you can remember them as P for Parkinsonism, which is drug induced Parkinsonism. So first generation drug can be used in drug induced Parkinsonism. The drug used mainly is promethazine. Then A for acute muscular dystonias and akathisia. C is common cold. And P is prophylaxis of motion sickness. So for these indications, we use first generation drugs, not the second generation drugs. Okay. And the important first generation drugs, as we have written already, the main one is promethazine. Apart from promethazine, we have diphenhydramine, cinnarizine, etc. These are first generation drugs. On the other hand, second generation drugs, they have only anti-allergic uses, no other uses. The important drugs being loratadine, cetirizine, agilastin, fixofenadine, and two drugs which are withdrawn now. These are estamizole and terfenadine. So both of these are withdrawn because of same side effect. They cause QT prolongation, which can lead to torsades de pointes. Okay. So that is important about histamine. Now coming to serotonin. Serotonin act on various receptors, important ones being 5-HT1A and 1B. You can write 1A and 1B. 1B is also written as 1D. Then 5-HT2A 2C receptors, 5-HT3 receptors and 5-HT4 receptors. Now 5-HT1A, you can remember the agonist of 5-HT1A is used to treat anxiety. So A for agonist, A for anxiety, used to treat anxiety. The drug used is buspirone. Buspirone. Remember another drug with very similar name, which is bupropion. Bupropion. It is not for anxiety, it is anti-smoking drug. From the name you can remember PO. It is saying Sutapio. So PO means pion, it is anti-smoking, whereas buspirone is anti-anxiety. Then 5-HT1B, 1D receptor, they are present in B for blood vessels of brain. They are present in blood vessels of brain and they cause vasoconstriction. And in which condition we want to cause vasoconstriction in the brain? Yes, for headache. So these are the drugs which are used in migraine. So quickly discussing little bit about migraine. Migraine, the patient usually present with a unilateral pulsatile headache. There is symptoms of aura sometimes like photophobia, phonophobia and other symptoms are there. So in migraine, for acute attack, drug of choice are triptans. Triptans like sumatriptan, naratriptan, rositriptan, they are drug of choice for migraine, acute severe migraine, apart if the headache cannot be controlled by NSAIDs. Obviously, first of all, we will try NSAIDs. If NSAIDs are not able to control for severe migraine, we can use triptans. Another thing, triptans are also drug of choice for cluster headache. Triptans can be used for cluster headache also. Migraine, they are drug of choice. Second thing, triptans, apart from triptans, another drug we can use is ergotamine. But ergotamine can cause severe vasoconstriction in the periphery, which can lead to gangrene. So we prefer triptans over ergotamine. But whenever used, we have to use any one of them, not both of them. They should not be given together. Okay. Another drug, both of these drugs, they act by stimulating 5-HT1B, 1D receptors. These are drug of choice for acute migraine. Then coming to prophylaxis, when the attacks are severe, the drug of choice for prophylaxis is propranolol. Propranolol or beta blockers, they are drug of choice for prophylaxis of migraine. Now there are some new drugs in migraine. The new theories say that migraine is due to calcitonin gene related peptide. So we have to decrease that to treat migraine headaches. So we have developed several drugs. One of them is 5-HT1F agonist. 1F agonist. The drug group is called as ditans. Any drug whose name ends with the ditan, example is lasmiditan. Then another drug which can inhibit the release of CGRP, or we can say CGRP antagonist here in this case. So these drugs are called as GPANTs. GPANTs, the drug whose name ends with GPANT, like Olsi GPANT, Rime GPANT, Ubro GPANT. So these are drugs which block CGRP receptors, and both of these GPANTs and ditans are oral drugs and are used for acute attack of migraine. Then we have also developed monoclonal antibody against CGRP receptors, and these monoclonal antibodies are obviously injectable drugs, but they are long acting, so they are used for prophylaxis of migraine. These drugs include arenumab, galcanezumab, fremanezumab, and aptinezumab. These are monoclonal antibodies against CGRP used for prophylaxis of migraine, injectable drugs. Okay, so these are the important points regarding the new drugs for migraine. Then apart from 5-HT1, coming to 5-HT2 receptors, the drugs blocking 5-HT2 receptors are antipsychotic drugs, particularly atypical antipsychotic drugs like olanzapine, clozapine, etc. They are 5-HT2 blockers. Then 5-HT3 causes vomiting. It is present in CTZ. The blocker of 5-HT3 are used for treatment of vomiting, and the drugs end with cetron like ondansetron, granisetron, palonosetron. Cetrons are drug of choice for chemotherapy induced nausea, vomiting. They are drug of choice for anti-cancer drug induced vomiting. Then 5-HT4 receptors, they are present in the GIT and increase peristalsis. So the drug which stimulate them, that means agonist, they are used as prokinetic drugs. The drugs like cisapride, mozapride, they are 5-HT4 agonist, proquillopride, 5-HT4 agonist, they are prokinetic drugs. Cisapride is withdrawn because of QT prolongation. Okay, so this is about the second of the autocoid, which is serotonin. The third one is prostaglandins. We know prostaglandins are formed from phospholipids in the membrane, which are metabolized by phospholipase A2 to form arachidonic acid. Arachidonic acid, if acted upon by COX, produce prostaglandins, and if acted upon by LOX, produce leukotrienes. Okay. So we have drugs which act as prostaglandins, and some are drugs which inhibit prostaglandins. In particularly the drug which inhibit COX, cyclooxygenase inhibitors, they are called as non-steroidal anti-inflammatory drugs. So we will talk mainly about non-steroidal anti-inflammatory drugs, NSAIDs. So non-steroidal anti-inflammatory drugs, the mechanism is they inhibit COX, and we have two type of COX inhibitors, one which inhibit both COX-1 and COX-2, non-selective COX inhibitors, and second which primarily inhibit COX-2 only. The basic difference between the two groups is a non-selective COX inhibitor is relatively safe, or we can say less risk of causing peptic ulcer disease, whereas these have high chances of causing peptic ulcer disease. But selective COX-2 inhibitors, they increase the risk of thromboembolism like myocardial infarction or stroke. Now the drugs which are non-selective COX inhibitors first. The main drug you need to remember is aspirin. Apart from aspirin, little bit you need to know about paracetamol, ibuprofen, and indomethacin. So aspirin, we know most of the NSAIDs, they are used for three functions. That means to treat fever, pain, and inflammation. So aspirin is also used for that. Aspirin in addition has one more use, which is antiplatelet use. Important, for antiplatelet action, the dose required is low. So less than 325 milligram, usually 75 milligram or 150 milligram is used for antiplatelet action. So it can be used for prophylaxis of myocardial infarction and stroke. And it has been found at this dose, at low dose, aspirin primarily inhibit formation of thromboxane A2. By inhibiting cyclooxygenase, it can inhibit both thromboxane A2 as well as prostacyclin, but at low dose, main inhibition is of thromboxane A2, so that A for aggregation, so platelet aggregation will not occur. So mainly used as antiplatelet drug. Then aspirin, second important thing, aspirin is contraindicated in gout because it can cause hyperuricemia. Aspirin increases uric acid, so contraindicated in gout. Aspirin is contraindicated in children with viral illness because of risk of Reye syndrome. Child with viral illness may develop Reye syndrome, so aspirin is contraindicated. And lastly, aspirin overdose, or we can say toxicity, we do not have any antidote. The only method we have is to make the urine alkaline by giving sodium bicarbonate. Sodium bicarbonate will make the urine alkaline, that will help in excretion of aspirin in the urine. Okay. Now coming to paracetamol, the other name of paracetamol is acetaminophen. Paracetamol has little bit exception that it has no anti-inflammatory activity. So among the drugs which are NSAIDs, this does not possess anti-inflammatory activity, and it is assumed that this action occurs because it do not inhibit COX-1 or 2, rather it is inhibiting COX-3 in the brain. Then paracetamol, it has lesser nephrotoxicity as compared to other NSAID. Almost all NSAIDs can cause renal damage on long-term use. Paracetamol has lesser risk, so it is preferred in a patient with renal disease. Then paracetamol, on metabolism, it produces a compound called as NAPQI, which can cause liver damage. And the antidote for paracetamol is N-acetylcysteine. N-acetylcysteine is antidote for paracetamol. Lastly, acetaminophen or paracetamol, partly its analgesic mechanism is contributed by action on a receptor called as vanilloid receptor, which is called as transient receptor potential vanilloid. It acts on these receptors which produce analgesic effect. A metabolite of paracetamol is assumed to be acting on these receptors. Okay. Then moving to next drug, indomethacin. Indomethacin, it was commonly preferred, or we can say drug of choice for treatment of patent ductus arteriosus. But nowadays, ibuprofen has become drug of choice. Even indomethacin can be used, but ibuprofen has lesser risk. So now ibuprofen is drug of choice for patent ductus arteriosus. But if we give them early or late in the pregnancy, before the delivery, there is a risk of premature closure of ductus arteriosus. Now ibuprofen is the only anti-inflammatory drug which is approved in child. Remember, in children only two drugs are approved. One is paracetamol, second is ibuprofen, and ibuprofen has anti-inflammatory activity, whereas paracetamol do not. Okay. So these are important points regarding the NSAIDs also. So we completed the autocoids along with NSAIDs. So NSAIDs have two major clinical uses. We are going to discuss that. One is gout, second is rheumatoid arthritis. Starting with gout. We know gout is increase in uric acid. So gout can be acute gout. So patient present with deposition of uric acid in the joints. Most commonly, first metatarsophalangeal joint is involved. There is pain and inflammation of joints. Because there is pain, there is inflammation, so drug of choice are NSAIDs. So any NSAID we can prefer except aspirin or paracetamol. Aspirin cause hyperuricemia, so not used, and paracetamol does not possess anti-inflammatory activity. So other NSAIDs can be used, they are drug of choice. If NSAIDs are not effective, we can try steroids, particularly intra-articular steroids. And if they are not effective, then we have the strongest drug called as colchicine. Colchicine is the most effective drug for acute gout. Colchicine acts by inhibiting the granulocyte migration. It acts by inhibiting the granulocyte migration, but it is not preferred because of side effects. Particularly, it can cause myopathy and intractable diarrhea. So because of these two side effects, we use colchicine when we cannot manage gout with any other drug. Okay. On the other hand, in chronic gout, the patient is mostly asymptomatic. So person is not having pain or inflammation, NSAID do not have major role. So here we will want to decrease uric acid. So how to decrease uric acid? So for decreasing uric acid, we have three methods. One, we can inhibit formation of uric acid. Second, we can increase excretion of uric acid. And fourth, we can increase, third, we can increase metabolism of uric acid. Now, how to decrease formation? For that, we need to know how it is formed. So uric acid is formed from purines and proteins in the body, which are metabolized to form xanthin. And xanthin is metabolized by an enzyme called as xanthin oxidase to form uric acid. So drug which inhibit xanthin oxidase can be used in gout. And these drugs include allopurinol and febuxostat. Allopurinol and febuxostat. Febuxostat, the name says xanthin oxidase को static कर देती है. Okay, and allopurinol is a drug of choice for chronic gout. Okay, then we can increase excretion of uric acid. The drugs increasing the excretion of uric acid are called as uricose uric agents. Uricose uric agent, they will excrete the uric acid in the urine. So plenty of fluid must be taken with these drugs so that it become diluted in the urine and do not cause obstruction. The drugs like probenecid and a new drug called as lesinurad, these act by increasing the excretion of uric acid, but these are avoided in patient with renal failure. Okay, then drug which can increase metabolism. So in humans, uric acid cannot be metabolized further, but in birds there is an enzyme called as uricase which can oxidize uric acid to allantoin, and allantoin is water soluble and do not get precipitated anywhere. So we can give this uricase enzyme by making it through recombinant DNA technology, and the drug is rasburicase. Rasburicase, it is nothing but recombinant uricase enzyme, and from the name you can find that name contains uricase. And rasburicase, it increases the metabolism of already present uric acid, so it is the fastest urate lowering agent. Fastest urate lowering agent. And another advantage is that when we want to decrease uric acid quickly, as in patients of tumor lysis syndrome, we will prefer rasburicase. It will quickly decrease uric acid by metabolizing it. Okay? A new drug which is similar to rasburicase is pegloticase. It can also be used in chronic gout. Okay? So these are the important drugs in gout. Moving to last topic of autocoils, it is rheumatoid arthritis. As the name tells, there is itis means inflammation. So we will use NSAIDs. And if NSAIDs are not able to relieve pain or inflammation, we will use steroids. But these drugs do not decrease progression of the disease. So decreasing the progression of disease, we use another drug called as DMARDs, disease modifying anti-rheumatoid drugs. All of these are very slow acting. They require minimum 1 month, maybe 2 to 3 months to start their action. So the new name of them is slow acting anti-rheumatoid drugs. So DMARDs or SARDs are same thing. SARD is slow acting anti-rheumatoid drug. And we have three categories of DMARDs. Mainly two we can divide. DMARDs we can divide it into two main categories. One are known as conventional DMARDs, the drugs which we are using since long time, and second which we have made by recombinant DNA technology. These are called as biological DMARDs. Starting with the conventional DMARDs. The important conventional DMARDs you can remember from the mnemonic cute and Pagli Malika Sherawat. So you can remember that cute and Pagli Malika Sherawat. These are conventional DMARDs. C for chloroquine. Chloroquine, mainly we use hydroxychloroquine. P for penicillamine. Penicillamine. A for azathioprine. Azathioprine. G for gold salts. L for leflunomide. I for inhibitors of Janus kinase or JAK inhibitors, M for methotrexate, and S for sulfasalazine. The important conventional DMARDs. The MCQs which are asked about these, chloroquine is DMARD of choice in pregnancy. No other DMARD is safe in pregnancy. So if we want to give DMARD in pregnancy, the choice is hydroxychloroquine. Penicillamine additional use is in copper poisoning and Wilson's disease. So it is used in rheumatoid arthritis but can be used in copper and Wilson's disease. Then inhibitor of Janus kinase like baricitinib and tofacitinib. These are oral drugs, Janus kinase inhibitors. They can be used in rheumatoid arthritis, and baricitinib has also been tried in COVID. Then methotrexate is a drug of choice as DMARD, most commonly used DMARDs and drug of choice for DMARD. It requires liver function testing because it can cause liver damage, and the main mechanism in rheumatoid arthritis is by increasing adenosine. Adenosine has very strong anti-inflammatory activity. Okay. Then lastly, sulfasalazine. Important points are sulfasalazine number 1 is a prodrug. It is metabolized to active product. Second, sulfasalazine is the only DMARD which can also act as a disease modifying agent in ankylosing spondylitis. So not only rheumatoid arthritis, also ankylosing spondylitis. The third use of sulfasalazine is ulcerative colitis. Sulfasalazine also used for ulcerative colitis. So these are the conventional DMARDs. Then moving to biological DMARDs. So we have mainly 4 types of biological DMARDs, mainly targeting the culprits in the rheumatoid arthritis. So we can target interleukin 1, interleukin 6, TNF alpha, and the last one we will say is co-stimulation inhibitor. The drug which is antagonist of interleukin 1 receptor is anakinra. Anakinra is interleukin 1 receptor antagonist. The name says kin means interleukin receptor antagonist. Then we have drug which inhibit interleukin 6. These include tocilizumab and sarilumab. Now, apart from rheumatoid arthritis, these drugs are also used for cytokine release syndrome. Cytokine release syndrome. As in case of COVID-19, there are cytokine release syndrome. Sarilumab, from the name you can remember, it is monoclonal antibody against interleukin 6, S for 6, used in rheumatoid arthritis. Okay. Then drugs which are TNF alpha blockers. TNF alpha blockers, you can remember them as ACE inhibitors को गोली मारो. AC inhibitor को गोली मारो. The drugs include adalimumab, certolizumab, etanercept, infliximab, and golimumab. These are TNF alpha blockers. Now, apart from rheumatoid arthritis, they are also used in Crohn's disease and psoriasis. The other users apart from rheumatoid arthritis are Crohn's disease and psoriasis. But important thing is they increase the risk of infections. So before starting them, we have to rule out any infection. In particular, they are contraindicated if there is tuberculosis or hepatitis B. These are absolutely contraindicated even if they are subclinical TB and hepatitis B. Okay. Then lastly, the drug is co-stimulation inhibitor. Basically, it will inactivate T cells against the cells of the cartilage, and T cells become anergic. And what is the drug? Drug is abatacept. Abatacept. It inhibits the interaction of CD80-86 with the B28. So this is the main drugs which are used in rheumatoid arthritis. The next topic we are going to discuss is cardiovascular system. In CVS, we will start with the treatment of congestive heart failure. The problem is heart is not pumping effectively. So when the heart is not pumping, the fluid accumulate in the backward areas. So that leads to congestive symptoms like there may be breathlessness because of pulmonary edema, or there may be hepatomegaly because of accumulation of fluid in the liver, or there may be increase in JVP. So the drugs which are used in acute CHF, in such conditions, there are 2 main drugs. One which are diuretics, they will remove the fluid which has accumulated, and second are inotropics, which will cause increase in contractility of the heart. The diuretic which we commonly prefer are loop diuretics. Furosemide, torsemide are the examples. These are used in acute CHF. They will remove the pulmonary edema very quickly. In addition to their diuretic action, they are powerful vasodilators that help in pulmonary edema. Then inotropic drugs can be beta 1 agonist. Beta 1 agonist drugs like dopamine, dobutamine, noradrenaline, isoprenaline, they can be used. Dobutamine is usually the preferred inotropic drug. Then apart from beta 1 agonists, there may be phosphodiesterase inhibitors, which are also known as inodilators. Inodilators. The drugs include amrinone and milrinone. Amrinone and milrinone. These are phosphodiesterase inhibitors or inodilators drugs that can be used in acute CHF. Now what happens if a person is having acute CHF, the body start compensatory mechanisms. It will increase the sympathetic activity because heart is not pumping, so sympathetic activity increases. So in CHF, in acute CHF, when there is low cardiac output, that lead to increase in sympathetic activity, that will increase catecholamines like adrenaline, noradrenaline, and that will stimulate the beta 1 receptors that will maintain the cardiac output. So beta 1 receptor will increase the contractility, that is the compensatory mechanism. But this beta 1 overactivity in the kidney, in the JG cells of the kidney, it lead to release of renin. And renin convert angiotensinogen to angiotensin first. Then angiotensin first is converted to angiotensin second with the help of enzyme ACE. Then angiotensin second stimulate the AT1 receptors, which are present at several places, which can lead to vasoconstriction, which can release catecholamines like adrenaline or adrenaline, and they can release aldosterone. This aldosterone causes retention of sodium and water. It causes removal of potassium and hydrogen. Now, one problem with sympathetic overactivity is there is vasoconstriction due to catecholamines because they not only act on beta but also alpha, leading to vasoconstriction, which will increase preload and afterload. They will also cause vasoconstriction here, increase in preload afterload. Second, they cause edema because of sodium and water retention. And the third and most dangerous problem is they increase aldosterone constantly, which can lead to left ventricular hypertrophy or cardiac remodeling, and it is this which will lead to death of the person. So cardiac remodeling will occur, and that will lead to death of the person. So in chronic CHF, this type of scenario is called as chronic CHF or compensated CHF. In compensated CHF, the aim of treatment is totally different. Cardiac output is almost normal, so inotropic drug do not play that major role. So in chronic CHF, the aim of treatment will be, in chronic CHF, the aim of treatment will be to decrease the work of heart, to remove the fluid which has accumulated, and to prevent the left ventricular hypertrophy. And rarely we want to give inotropic drugs if the output is still not maintained even after compensatory mechanisms. So how to decrease work? Work is increased because of vasoconstriction. So we will give vasodilators. They will reduce the work. So vasodilators, we have drugs which dilate arteries like hydralazine. Drugs which dilate veins like nitrates. And the drugs which dilate both arteries and veins, these include sodium nitroprusside, ACE inhibitors, and angiotensin receptor blockers. The drug which dilate arteries, they decrease preload. Hydralazine decrease preload. Hydralazine decrease afterload. Nitrate decrease preload, whereas nitroprusside receptor decrease both preload and afterload. Then drug which decrease fluid, we all know it is loop diuretics. Loop diuretics like furosemide, torsemide, they are used to decrease fluid. Then this is the important drug, the drug which decrease left ventricular hypertrophy, they will decrease mortality, or we can say they will increase longevity of this person. No other drug can decrease mortality. Remember, dopamine, dobutamine, nitroprusside, hydralazine, they are drugs which only decrease symptomatic relief. But the drug which decrease mortality are which decrease left ventricular hypertrophy, and that is done by 4 type of drugs. Right in the beginning, beta blockers, the drugs whose name end with lol, like metoprolol. ACE inhibitors, drugs whose name end with pril, like captopril, lisinopril. AT1 receptor blockers, the drugs whose name end with sartan. And aldosterone antagonist is spironolactone. So these are the main drugs which decrease mortality in congestive heart failure. Other drugs do not decrease mortality. Then moving to the last drug, which is inotropic drugs. Now inotropic drugs we were using in acute CHF also, but in chronic CHF also. The important thing is a drug which is useful in chronic CHF must be given orally. The drugs like dopamine, dobutamine, they are not effective orally. So we cannot use them in chronic CHF. In chronic CHF, we use oral inotropic drug, and the main drug is digoxin group of drugs. Digoxin is the drug which is used. Now digoxin, important thing, it has two mechanisms. One, it inhibits sodium potassium pump. By inhibiting this pump, it causes increase in intracellular calcium, which can lead to increase in contractility. So this mechanism is used in CHF. But second, it has vagomimetic effect also. Like vagus, it will decrease the conduction from atrium to ventricle. That is used in atrial fibrillation. So digoxin is used not only for CHF but also for atrial fibrillations. The major side effect of digoxin include most common being GI side effects like nausea, vomiting. Then it can cause almost any arrhythmia. The most common arrhythmia noted with digoxin is ventricular bigeminy. And most specific or most characteristic is non-paroxysmal atrial tachycardia with AV block. Non-paroxysmal atrial tachycardia with AV block is the most specific arrhythmia caused by digoxin. Apart from this, it can cause gynecomastia. The other drugs causing gynecomastia or development of male breasts, you can remember from the mnemonic DISCO drugs. So DISCO drugs stand for DI is digoxin, which we are studying. S is spironolactone, C is cimetidine, and O are estrogens. Spironolactone, cimetidine, estrogens. And lastly, it can cause color vision defects, which is called as xanthopsia or yellow vision. Normally, it causes in the beginning non-specific visual defects, but gradually it turns toward yellow vision or xanthopsia. These are the major side effects. Now coming to the main factors which increase the risk of toxicity of digoxin. Digoxin toxicity, it is likely in three conditions. One is electrolyte imbalance, like there is hypokalemia, hypomagnesemia, or hypercalcemia. These factors increase the risk of digoxin toxicity. Then certain drugs like quinidine, verapamil. Along with verapamil, by similar mechanism, we have clarithromycin, amiodarone, and thiazides. They increase the risk of toxicity. You can remember, अगर digoxin देंगे तो queen की वाट लग जाएगी. So quinidine, verapamil, amiodarone, thiazide, they increase the risk of toxicity. And lastly, it is renal failure. In case of renal failure, digoxin become toxic. So digoxin toxicity can occur. Okay. Now, if toxicity occurs, what will happen? So there will be arrhythmias. Person will have nausea, vomiting, and then the person will have arrhythmias. So the drug of choice for digoxin-induced ventricular arrhythmias. For ventricular arrhythmia, drug of choice is lidocaine. Lidocaine or lignocaine is drug of choice for ventricular arrhythmia. And if they cannot be controlled or there are other arrhythmias, then we can use a drug known as digoxin immune fab. This is a fraction of antibody against digoxin, which is also known as digibind. So this will bind digoxin and stop its action, used in severe digoxin toxicity. Okay. So these are the traditional drugs we use in congestive heart failure. Now coming to some new drugs in CHF. The new drugs, mainly the new target is brain natriuretic peptide or BNP. The function of BNP is to cause natriuresis. The name says loss of sodium. And second, it is a powerful vasodilator. In CHF, we want these two things. So we want to increase BNP. But normally BNP after production is metabolized in the body with the help of an enzyme called as NEP, neutral endopeptidase. So we can give BNP from outside. The drug is naziretide. This is recombinant BNP. Problem with the naziretide, number one, it is given IV, not effective orally, and second, it is very short acting. So it is suitable only for acute CHF. Second, we can give NEP inhibitor or neprilysin inhibitor, the drug whose name ends with the trill, like sacubitril, that can be used for CHF. Then we have developed a combination of AC inhibitor, that means pril with NEP inhibitor, that is trill. So this combination prill plus trill, this is known as petrilet. Petrilets like omapetrilet and sampetrilet, they have properties of both prills and trills, prill and trill. Okay, so these are the new drugs in congestive heart failure. Okay, now moving to the second topic in congestive heart failure, it is hypertension. Hypertension we know is increase in blood pressure. The four main group of drugs used in hypertension are diuretics, vasodilators, sympathetic system blockers, and renin-angiotensin-aldosterone system blockers. Four type of drugs are used. Starting with the diuretics, the diuretic of choice in hypertension are thiazides. Thiazides are drug of choice for hypertension, and one of the thiazide called as metolazone, it is effective even in the presence of renal failure. Even in renal failure, normally diuretics like thiazides, they are not effective in renal failure, but metolazone remain effective. Then coming to vasodilators, now we have some methods of causing vasodilation, like a drug may act by releasing nitric oxide, which will increase cyclic GMP, that can cause vasodilation. So drugs acting by this mechanism include drugs like sodium nitroprusside and hydralazine. They act as a vasodilator by releasing nitric oxide. Now these drugs are used in hypertensive emergencies. Then second, we have mechanism to open potassium channels, potassium channel openers. So these drugs, they are remembered as MDH. Drugs include minoxidil, digoxide, and hydralazine. So you can remember MDH के potassium वाले मसाले, MDH के potassium वाले मसाले. So minoxidil is a prodrug, and minoxidil can cause hair growth. So it can be used in treatment of alopecia and can cause hirsutism as side effect. Digoxide DI, it will decrease insulin. So it is preferred in insulinoma but can cause hyperglycemia. And hydralazine we already discussed. Then the third mechanism is calcium channel blockers. Calcium channel blockers. Three group of drugs we have. One is verapamil. Second is diltiazem. And third, any drug ending with the dipin, like nifedipine, amlodipine, nicardipine. So these drugs can be used in hypertension. Special point to remember, these are blocking calcium channel. So by blocking calcium channel in the GIT, they can decrease peristalsis. So the main side effect of these drugs is constipation. They can cause constipation. Side effect of calcium channel blockers. Now, second important thing to remember, calcium channel blockers, verapamil and diltiazem, they not only decrease BP but also decrease heart rate. Whereas dipins, they are peripheral calcium channel blocker. They do not act on heart, only on the blood vessels. So they can cause reflex tachycardia. They can cause reflex tachycardia. Okay? And in particular, a dipin known as nicardipine, it is a drug of choice for hypertensive emergencies. Nicardipine is drug of choice for hypertensive emergencies. Okay, there is one more dipin called as nimodipine. Nimodipine is a cerebroselective calcium channel blocker. It mainly dilates blood vessels in the brain. So it is used to reverse the vasospasm in subarachnoid hemorrhage. This is the commonly asked question: which calcium channel blocker is used in subarachnoid hemorrhage? It is nimodipine. Now, apart from hypertension and these conditions, calcium channel blockers are drug of choice for peripheral vascular disease called as Raynaud disease. Raynaud's disease, calcium channel blockers are drug of choice. Okay. So, second group of drugs we have covered in hypertension, these are vasodilators. Third group are sympathetic blockers. So, sympathetic blocking drugs may be alpha 2 agonists, which will press the brakes, and the drugs include clonidine and methyl-dopa. Clonidine and methyl-dopa. Methyl-dopa, the characteristic side effect you need to remember is hemolytic anemia. Both of these can be used in pregnancy. Methyl-dopa can cause hemolytic anemia. Then second, there may be alpha blockers, alpha 1 blockers, and there may be beta blockers. So alpha 1 blockers, drugs ending with the josin like parajosin we discussed earlier, and beta blockers, drugs ending with the lol, they can be used in hypertension. Then lastly, we have renin-angiotensin-aldosterone system blockers. 5 drugs in this category, starting with beta 1 blockers, which is inhibiting the release of renin. So remember, they inhibit secretion of renin. They do not inhibit renin but secretion. Second, we have renin inhibitor. The enzyme is inhibited by the drugs like aliskiren, the drug whose name ends with kiren. Aliskiren, ramikiren, enalkiren. Drugs ending with kiren, the name says they will inhibit renin. They are oral renin inhibitors, and all the drugs of RAS inhibitor group, they will inhibit the removal of potassium. So all RAS inhibitors can lead to hyperkalemia. All RAS inhibitors can lead to hyperkalemia. Then third group are AC inhibitors. The name will end with pril, like captopril, lisinopril, enalapril like drugs. And all the important properties about prils you can remember from the first drug captopril. So captopril, it says it causes cough and angioedema. Angiotensin converting enzyme not only convert angiotensin first to second, but it is also involved in metabolism of bradykinin. So by inhibiting this, AC inhibitor will increase bradykinin that can lead to cough and angioedema. This side effect is not seen with sartans. It is seen only with prils. Then most of the AC inhibitors are pro-drugs except two prils. One is captopril and second is lisinopril. They are not pro-drugs. All other are pro-drugs. Then they can cause disturbance of taste known as dysgeusia. They can cause orthostatic hypotension, postural hypotension, particularly when combined with the diuretics. They are contraindicated in these three situations. These are pregnancy, absolutely contraindicated in pregnancy, contraindicated in bilateral renal artery stenosis, and contraindicated mean increased potassium, that means hyperkalemia. Then lastly, they are very good drug for diabetic nephropathy, lower the risk of diabetic nephropathy. So good drug for diabetic patients. So these are important points regarding the AC inhibitors. ARBs, angiotensin receptor blockers, their name end with the sartan, like losartan, valsartan, telmisartan, etc. drugs. All the properties are similar to AC inhibitors. Only important difference is they do not cause cough and angioedema and they are not pro-drugs. So rest of the properties are same as with prils in sartans. And one of the sartans, which is telmisartan, it has additional role apart from the other AC inhibitors. What is that additional role is? It is stimulator of PPAR gamma. PPAR gamma agonist, and this PPAR gamma agonistic activity will decrease insulin resistance. So it is another advantage in the diabetic patients. So which ARB is PPAR gamma agonist? It is telmisartan. Okay. So these are important 4 group of drugs in hypertension. The last and most important thing in hypertension is asked drug of choice for different type of hypertensive conditions. Normally for hypertension, drug of choice we consider is thiazides. For hypertensive emergency, usually the drug of choice is nicardipine. Nicardipine is drug of choice. The other drugs we can use are nitroprusside, sodium nitroprusside. We can use nitrates also. The other drug we can use in hypertensive emergencies are beta blockers, which are fast acting like Asmol. But very important to remember, in hypertensive emergencies, mannitol has no role at all. Mannitol is for cerebral edema. It is not for hypertensive emergency. Okay. Then hypertension in pregnancy, if we talk, drug of choice for hypertension in pregnancy is labetalol, both for hypertension as well as hypertensive emergency. The alternative to labetalol for hypertension is methyl dopa, but it is slow acting, so not for emergencies. Can be used in hypertension, but not for emergencies. Okay, but AC inhibitors and ARBs are absolutely contraindicated in pregnancy. So these are important points regarding the hypertension. The next topic in cardiovascular system is angina pectoris. So we'll discuss basically ischemic heart disease, which include angina and MI. So angina, it may be classical or it may be variant. The basic problem in classical angina is there is decrease in blood supply to the heart because of obstruction. Okay? So the main treatment of classical angina is to increase the blood supply, whereas variant angina is due to vasospasm. also known as Prince metal angina. So the only treatment in variant angina is dilation of coronary artery. Okay. So moving to drugs in angina, traditionally we are using 4 type of drugs: nitrates, calcium channel blockers, beta blockers, and potassium channel openers. Now nitrates, they act by releasing nitric oxide, which will increase cyclic GMP, that will cause vasodilation, and they dilate veins more than arteries. So the dilation of veins mainly will decrease preload. So main mechanism of action of nitrates in classical angina is a reduction in preload. Whereas if they ask main mechanism of nitrates in variant angina, the answer will be dilation of coronary artery, because nothing else will be useful in that. Now nitrates, the drugs include glyceryl trinitrate or nitroglycerin. We have isosorbide dinitrate. We have isosorbide mononitrate, penta-erythritol tetranitrate, and amyl nitrite. 5 type of nitrates are there. The important point to remember, all of these, they have very high first pass metabolism. So they have very poor oral bioavailability. So they are usually preferred by alternative route, which is sublingual. So in fact, first 2 drugs, they are given by sublingual route, and they are drug of choice for acute attack of angina. Second, isosorbide mononitrate has minimum first pass metabolism. So from the name you can remember, इसका metabolism नहीं होता. IMN इसका metabolism नहीं होता, minimum first pass metabolism. Then PETN, the longest name is longest acting nitrate, whereas nitrite is the shortest acting nitrate. Lastly, if we give nitrates continuously for prolonged periods, if they are present constantly in the blood, that will lead to tolerance. So there must be nitrate free period, minimum 6 to 8 hours nitrate free period to maintain their efficacy. Otherwise, they will become ineffective. Lastly, nitrates, they increase cyclic GMP, that is causing vasodilation. But cyclic GMP is metabolized by an enzyme called phosphodiesterase. So when we give nitrates, they increase cyclic GMP. But along with this, if we give phosphodiesterase inhibitor like sildenafil, then cyclic GMP cannot be broken. So there will be extreme vasodilation that can lead to severe hypotension. So because of this risk, severe hypotension, nitrate should never be given with sildenafil or any phosphodiesterase inhibitor. Sildenafil, the question asked is which is longest acting phosphodiesterase inhibitor? It is tadalafil. Tadalafil is longest acting phosphodiesterase inhibitor. Okay. So these are important points regarding the first drug in angina, nitrates. Then moving to calcium channel blockers, we already discussed. We have 3 drugs: verapamil, diltiazem, and dipins. Among these, verapamil and diltiazem can be used in angina, but dipins are contraindicated because they cause tachycardia that can worsen angina. So dipins, we can use verapamil or diltiazem. Third drug, beta blockers. What is special about beta blockers are they are used only for classical angina, but they are contraindicated in variant angina. Dipins are contraindicated in variant angina. Calcium beta blockers are contraindicated in variant angina. Other drugs like nitrate, calcium channel blockers, and even potassium channel openers can be used for both type of angina. The last drug in the classical category are potassium channel opener, and the drug is nicorandil. Nicorandil not only is a potassium channel opener, but also releases nitric oxide. And from the name you can remember, it is saying nitric oxide releaser, and if we keep I and C together, it will become like K. So it is potassium channel opener and nitric oxide releaser, nicorandil. So these are the drugs we traditionally use in angina. Now moving to some new drugs in angina. So first of all is metabolic modulators. Normally, heart utilizes fatty acids for producing energy, but fatty acids are poor fuels, so they require too much oxygen to metabolize. So if we shift the metabolism of heart to glucose instead of fatty acid, then the oxygen utilization become better. So that is the new strategy. These are fatty acid oxidation inhibiting drugs. The drugs like trimetazidine and ranolazine. These are fatty acid oxidation inhibitors, and from the name you can remember meta, so it is a metabolic modulator. And ranolazine, a new mechanism is proposed now. It acts by inhibiting the late invert sodium channels. Late invert sodium channels is inhibited by ranolazine in addition to metabolic modulation. Then second, another drug is ivabradine. Ivabradine is a drug which acts by blocking the funny current. It is a funny current blocker. It acts by causing bradycardia, decrease in heart rate. Major side effects are visual field problems. All three are written in the name. You can see I means symbol of current. So it is funny current. It is funny current. VA means visual acuity problems, and brady means it causes bradycardia. Then third drug which is used in angina, new drug is rhokinase inhibitor. Rhokinase inhibitor, and the drug is fasudil. Fasudil is a rhokinase inhibitor used in angina. Okay. Now, related to angina, the second problem is myocardial infarction. It may be non-ST elevation MI or it may be ST elevation MI. For non-STEMI, the treatment is MONA. These are morphine, oxygen, nitrates, and aspirin. But on the other hand, in STEMI, we need to give sonum. If you see, 4 drugs are same: morphine, oxygen, nitrate, aspirin. The extra drug is streptokinase. So very important to remember, streptokinase or thrombolytic drugs are indicated only in ST elevation myocardial infarction. Okay? So that is important about the drugs used in ischemic heart disease. Moving to the next topic, which is antiarrhythmic drugs. We have various classes of antiarrhythmic drugs based on the mechanism of action. We divide them into class 1, 2, 3, 4, and 5. Class 1 drugs are sodium channel blockers. Class 2 are beta blockers. Class 3 are potassium blockers. Class 4 are calcium blockers. And any other remaining drug is class 5. So if we see, this is the normal action potential. Normal action potential. Class 1 drugs, they decrease the slope of phase 0. This is phase 0 of the action potential. So mechanism of all the class 1 drugs are decrease in slope of phase 0. Now class 1 drugs, they are further divided into 1A, 1B and 1C based on what they do to potassium. Class 1 are potassium blocker, class 2 are potassium opener, and class 3 have no effect on potassium. Remember, all are sodium blocker. So what will be the effect on action potential is, if this is the normal action potential, all the class 1 drugs are going to produce this action potential, that is decrease in slope of phase 0. 1A, they will increase APD, 1B will decrease APD, and 1C will have no effect on APD. So this is A, class 1A, this is class 1B, this is class 1C. Effect on action potential. Now drugs in this category, class 1A drugs include quinidine and procainamide. 1B drugs include lignocaine, phenytoin, and tokenite. And 1C drugs include enkenite and flecainide. Now what is important to remember, 1A drugs, they cause QT prolongation which can lead to torsades depointes, and from the name you can remember 1A, they are category 1A, A class log, A class people are hi-fi like queen and prince, and we know queen and prince, they are cute, QT prolongation, so they cause QT prolongation. Now class 1B drugs are used for ventricular arrhythmias only. Ventricular arrhythmias only. In particular, lignocaine is a drug of choice for ventricular arrhythmia due to digoxin overdose, as well as ventricular arrhythmia due to myocardial infarction. So post MI ventricular arrhythmia and ventricular arrhythmia due to digoxin overdose, drug of choice is lignocaine. Okay. Then class 1B drugs we discussed, they are beta blockers, class 2 drugs are beta blockers, they are used for tachycardias, maybe atrial, maybe ventricular. Moving to class 3 drugs, these are potassium channel blockers. So this is the normal action potential. The effect of class 3 drugs will be only this: increase in action potential duration. And the drugs in class 3 include bindas drugs. Class 3 drugs are remembered as Bindas drugs. So these include Bretilium, ibutylite, dofetilide, amiodarone, and sotalol. Now what is important, most important among them is amiodarone. The important points about amiodarone to remember: number one, it has all mechanism of action. That means it is not only sodium blocker but also potassium blocker, calcium blocker, and beta blocker. Second, amiodarone is very long acting. Its half-life is more than 3 weeks. Half-life is more than 3 weeks. Very, very long acting antiarrhythmic drug. And the side effect of amiodarone you can remember as the periphery of my lung and cornea is photosensitive. So TH stand for thyroid. It can lead to either hyper or hypothyroidism. Some people develop hyper, some hypo. It can cause peripheral neuropathy. Then it can cause myocardial depression. It can depress the heart, myocardial depression. Lung fibrosis, pulmonary fibrosis can occur. Then it can get deposited in the cornea. And it can cause photosensitivity. When the person is exposed to sunlight, the person develops bluish color discoloration on the face. That is known as blue man syndrome. It can cause blue man syndrome. Which drug can cause red man syndrome? Yes, that is vancomycin. It causes blue man syndrome. Okay. Then moving to class 4 drugs, calcium channel blockers. And calcium channel blockers, we all know we have 3 drugs mainly here: verapamil, diltiazem, and dipins. Dipins are not used in arrhythmias because they do not have any direct effect, and verapamil and diltiazem are used for tachyarrhythmias. They are alternative to beta blockers. Okay. Then class 5 or miscellaneous drugs. The important drugs in this include digoxin, adenosine, atropine, and magnesium. Digoxin is used in atrial fibrillation, particularly when it is associated with CHF. Adenosine is shortest acting antiarrhythmic drug. It is given IV very rapidly for treatment of an arrhythmia called as PSVT. It is drug of choice for PSVT. Atropine is drug of choice for bradyarrhythmias like bradycardia and AV block. Bradycardia and AV block, atropine is drug of choice. And magnesium is drug of choice for torsades de pointes. Torsades de pointes, the drug of choice is magnesium. Okay. So these are the important points regarding the antiarrhythmic drugs. Then moving to the next topic in cardiovascular system is pulmonary hypertension. It is different from systemic hypertension. Most of the drugs used in systemic hypertension, they cannot decrease the or we can say decrease the pressure in the pulmonary vessels. So here we need to use specific drugs. Pulmonary hypertension normally can be treated in very few patients by calcium channel blockers. So we give intravenous calcium channel blocker and see whether the pressure is reduced or not. That is known as intravenous vasodilator testing. If that testing is successful, then we will give calcium channel blockers orally. Okay? So they are drug of choice, but they are in very few patients, only 5% or even less. But for 95% of the patients or more, calcium channel blockers are not effective. The drug of choice are endothelin antagonists. The drug of choice for pulmonary hypertension are endothelin antagonists. The drugs like ambrisentan, bosentan, macitentan. These are drug of choice for pulmonary hypertension. Apart from these drugs, the other drugs which we can use in pulmonary hypertension, these include drugs like phosphodiesterase inhibitors, like sildenafil, tadalafil. They are also used in pulmonary hypertension. Then the most effective drugs are prostacyclins. Prostacyclins like epoprostenol, iloprost. These are prostaglandins and they are also useful in pulmonary hypertension, but they cannot be given orally. They are highly effective drugs in pulmonary hypertension. Then we have developed recently a drug called as selexipag, which can be given orally for pulmonary hypertension. The name says it is selective non-injectable. Cross means injection is not required. Prostacyclin agonist. It is the agonist of prostacyclin used in pulmonary hypertension. Okay. Now moving to last topic in cardiovascular system, this is anti-dyslipidemic drugs. And the most important drugs we all know are statins. Statins, they act by inhibiting the rate limiting enzyme HMG-CoA reductase. When this enzyme is inhibited, liver is not able to make cholesterol. So there is increase in number of LDL receptors over the liver, and that will take up the cholesterol from the blood. That will decrease cholesterol. Now statins, their name should end with vastatin, like atorvastatin, simvastatin, pravastatin. So their name should end with vastatin. Statins, the important points, statins, they are usually given at night time because the activity of HMG-CoA reductase is maximum at night. But rosuvastatin and atorvastatin, these are very long acting. They can be given any time of the day. The longest acting statin is rosuvastatin. Second thing, statins, they can cause major side effect as myopathy. Second, statins can cause liver damage, and they can cause hyperglycemia, means diabetes mellitus. These are the main side effects of statins. Now, there are important interactions of statins with the drugs, in particular drugs which cause myopathy like fibrates, or drugs which are CYP inhibitors like erythromycin or ciprofloxacin. They increase the concentration of statins, and that can lead to increased risk of myopathy. So that we should be careful about. Lastly, statins, they have many other effects which are beneficial. These are called as pleiotropic effect, like they have antioxidant effect. They cause stabilization of plaque. They decrease inflammation. So many other beneficial effects are there in the cardiovascular system. These are called as pleiotropic effects of statins. Okay. So these are important points regarding the first drug, statins. Then we have a drug as ezetimibe. This act by inhibiting the intestinal absorption of cholesterol. Ezetimibe inhibit intestinal absorption of cholesterol. Third group of drugs are fibrates like gemfibrozil, clofibrate. These are the drugs. These drugs, they act by stimulating a receptor called as PPAR alpha, and that will mainly decrease triglycerides. Remember, statins has maximum LDL cholesterol lowering potential, whereas fibrates have maximum triglyceride lowering potential. Okay. Next are bile acid binding agents. Bile acid binding agents, also called as BABA drugs, like cholestyramine, cholestyramine, The main advantage of these drugs are very safe in pregnancy and children. So these are drug of choice for dyslipidemia in pregnancy and children. They are not absorbed at all. But main disadvantage is they cause hypertriglyceridemia. So if there is already increase in triglyceride, they are contraindicated because they can result in pancreatitis in these patients. Next drug is niacin. Niacin is vitamin B3. It has maximum HDL cholesterol increasing potential. But the main problem is it has compliance limiting side effects like flushing and itching. These are due to release of prostaglandin D2, and that can be inhibited by either aspirin or a specific prostaglandin D2 antagonist known as laropiprant. Apart from flushing and itching, niacin can cause gout, that means increase in uric acid, and it is also contraindicated in diabetes mellitus because it causes insulin resistance. Now lastly, some new drugs in dyslipidemia. We have developed a new strategy called as PCSK9 inhibitors. Pre-protein converting subtilisin caxin type 9 inhibitor. This is a substance which help in degradation of LDL receptors on the liver. So when we give a monoclonal antibody against this, LDL receptor cannot be broken. So more LDL receptor, more intake of cholesterol from the plasma. And the drug like alirocumab and evolocumab, these are PCSK9 inhibitors. They are used in homozygous hypercholesterolemia. Then second of the new drugs, which is called as angiotensin lipoprotein like protein inhibitor. Now this is a protein which causes hyperlipidemia. So when we inhibit this, we can treat dyslipidemia, and the drug is avinacumab. Avinacumab. The major advantage of avinacumab over any other antidyslipidemic drug is it works independent of LDL receptor. Normally, most of the drugs finally act through LDL receptors. This does not require LDL receptors. Even if there are no LDL receptors, still this will be effective. But problem is it is injectable drugs. It is given IV. The name says IV. Avinacumab is not effective orally. Okay? So these are the important points regarding the cardiovascular system. Our next topic is diuretics. So diuretics, we can divide them based on their site of action. So if we quickly make a nephron, the diuretics, they may work on filtration, which is known as osmotic diuretics. We will discuss them. They can work at any place in the nephron. Then the diuretic may work on proximal tubule, which are carbonic anhydrase inhibitors. They may work on ascending limb of loop of Henle. They are called as loop diuretics. Diuretic can work on distal tubules, which are called thiazides. And lastly, diuretic working in collecting duct, they are known as potassium sparing diuretics. So quickly going through each one of these, starting with osmotic diuretics. Example is mannitol. So these exert the osmotic effect. So they attract water, that will lead to diuresis. And important thing in mannitol is it is used in cerebral edema. Mannitol is used in cerebral edema, but very important after the hemorrhage has stopped, because if the bleeding is ongoing, it will also be filtered and that will attract water and it will increase edema. So it is contraindicated during active cerebral hemorrhage. During active cerebral hemorrhage, it is contraindicated. And second, it is also contraindicated in pulmonary edema because it will increase the fluid in the lungs, that will worsen edema. So used for cerebral edema and sometimes also used for acute congestive glaucoma. Then second type of diuretics are carbonic anhydrase inhibitors. Examples like acetazolamide or any drug whose name ends with a zolamide. We have acetazolamide, dorzolamide, brinzolamide. Acetazolamide can be given orally as well as IV, whereas dorzolamide and brinzolamide are used as eye drops. Now these diuretics, these can be used in glaucoma, congestive glaucoma, basically angle closure glaucoma. Dorzolamide, brinzolamide as eye drops, whereas acetazolamide can be given orally or IV. Whereas acetazolamide, very, very important use is it is a drug of choice for treatment as well as prevention of mountain sickness. Acetazolamide is drug of choice for mountain sickness. These diuretics are not very strong diuretics. The major disadvantage or major problem is they cause loss of bicarbonate in the urine that lead to urinary alkalosis and metabolic acidosis. That is their major side effect. Apart from them, these can commonly cause paresthesia as the side effect. Okay. Then third and fourth group we will discuss together. Third group of diuretics are called as loop diuretics, whereas fourth are called as thiazides. Loop diuretics, they work on ascending limb of loop of Henle, where they inhibit a pump known as sodium potassium 2 chloride symport. Whereas thiazide work in distal tubules and they inhibit a pump called as sodium chloride symport. Now loop diuretics examples are furosemide, torsemide and bumetanide. Whereas thiazides, any drug whose name ends with thiazide like hydrochlorothiazide, chlorothiazide, polythiazide, any drug whose name ends with thiazide. And some drugs whose name do not end with thiazide like metolazone, indapamide, These are also called thiazide-like diuretics. They have same mechanism and similar uses. Now, what is the main difference between loop diuretics and thiazides is, loop diuretics are strong diuretics, also called as high ceiling diuretics, whereas thiazides are not that strong diuretics. Loop diuretics are usually short acting, but thiazide effect is long lasting. So due to these differences, loop diuretics are mainly used whenever there is a case of edema, as in case of congestive heart failure, there is pulmonary edema. In ascites, so wherever there is edema, to mobilize the fluid, we mainly use loop diuretics, whereas thiazides, they are mainly used in case of hypertension. They are first line drug in hypertension. Now, second thing, loop diuretics are usually effective even in the presence of renal failure. So, if there is kidney failure, loop diuretics remain effective, but most of the thiazides are not effective in presence of renal failure. The only important thiazide which is effective in the presence of renal failure is metolazone. So, if we have to use a thiazide, it should be metolazone in renal failure. Okay. Now, both loop and thiazides have some common side effects. They decrease all the ions in the blood, like they cause hypokalemia, hypomagnesemia, metabolic alkalosis, hyponatremia. They decrease all the ions, and they increase all the metabolic substances, like they cause hyperglycemia, hyperuricemia, and hyperlipidemia. That is the common side effect of loop and thiazide. The main difference is loop loses calcium. That means loop diuretics, they cause hypocalcemia, whereas thiazides, they cause hypercalcemia. Loop cause hypocalcemia, thiazide cause hypercalcemia, and because of causing hypocalcemia, loop diuretic have extra use, which is treatment of hypercalcemia, whereas thiazide can be used for treatment of osteoporosis. Now, apart from these, thiazides have paradoxical uses. Thiazide can be used for treatment of diabetes insipidus. In fact, they are drug of choice for diabetes insipidus, which is nephrogenic. That means the ADH is coming, but it is not able to work on the kidney. Then thiazides will be drug of choice for nephrogenic diabetes insipidus. Okay. Now, the last group of diuretics are potassium sparing diuretics, and they are of two types. One, which are epithelial sodium channel blockers, and second, they are aldosterone antagonists. Epithelial sodium channel blockers, examples are triamterene and amiloride, whereas aldosterone antagonists are spironolactone and eplerenone. Now, what is important is aldosterone antagonists are the only potassium sparing diuretic, or we can say only diuretic among all, which work from the basolateral side or the blood side of the nephron. All other work from the luminal side. Second important thing to remember, only this group of diuretics, they cause retention of potassium. All other diuretics like osmotic diuretic, loop diuretics, carbonic anhydrase inhibitors, all of them cause hypokalemia, but these can result in hyperkalemia. Okay. Now, spironolactone, it causes gynecomastia as the extra side effect. It causes gynecomastia, and it can cause menstrual abnormality in females. In males, it can cause gynecomastia, in females, menstrual abnormalities. And you can remember these drugs we discussed earlier also by DISCO. So DI for digoxin, S for spironolactone, C is cimetidine, and O are estrogens. They can cause gynecomastia. Now, aldosterone is elevated in liver disease. So, if there is cirrhosis with ascites, so there is edema due to cirrhosis, then the diuretics of choice will be spironolactone or eplerenone group, or basically aldosterone antagonist, because the problem is due to excessive aldosterone. Okay. So, these are the important points regarding the diuretics. The next topic we are going to cover is endocrine system. This consists of glands which secrete hormones. The first gland we are going to cover is pituitary hypothalamic system. Now, anterior pituitary secrete several hormones. These include growth hormone, thyroid stimulating hormone, adrenal corticotropic hormone, gonadotropins like luteinizing hormone, follicle stimulating hormone, and prolactin. And all these hormones are under the control of hypothalamus. Means some hormone from the hypothalamus come, they increase or decrease pituitary hormones. For growth hormone, hypothalamus secrete growth hormone releasing hormone and growth hormone inhibiting hormone. For TSH, hypothalamus secrete TRH. For ACTH, CRH. For gonadotropin, gonadotropin releasing hormone. And for prolactin, prolactin inhibiting hormone. Now, what is important? All hormones of anterior pituitary are under the control of hypothalamus, and hypothalamus secrete releasing hormone for all of them. That means if there is lesion between hypothalamus and pituitary, the releasing hormone cannot reach pituitary. So all these hormones will decrease because the releasing hormone is not coming. But prolactin, it is only having inhibitory control. So if there is a lesion, inhibitory hormone cannot come, so prolactin level will increase. So if there is a lesion between hypothalamus and pituitary, all anterior pituitary hormone will decrease except prolactin, which will increase. Second question which is asked is, all hormones of anterior pituitary are having releasing hormones, but prolactin is only under inhibitory control. Second, two hormones have inhibitory hormone from hypothalamus. One is growth hormone inhibiting hormone, second is PIH. So growth hormone and prolactin, these are the two hormones which are under inhibitory control, whereas prolactin is only under inhibitory control because there is no releasing hormone. Okay. Now the important anterior pituitary hormones to cover is growth hormone inhibiting hormone. The other name of this is somatostatin. And important uses of somatostatins are written in the first four letters. S for secretory diarrhea. O is esophageal varices. M is malignancy of endocrine pancreas, means insulinoma and glucagonoma, can be used in insulinoma, glucagonoma. And A for acromegaly. So used for 4 indications, but somatostatin is very short acting. So we will use a long acting derivative of somatostatin, which is octreotide. So octreotide is used for all these indications. And important to remember, octreotide, the name end with the tide means it is a peptide. So it cannot be given orally. So it is given by subcutaneous route. Second thing, for acromegaly, when the growth hormone is excess, the patient is having enlargement of the bones, like chin is protruding, height is very long. So in these patients, apart from using octreotide, we can use another drug which is growth hormone receptor antagonist. It is called as pegvisomant. Pegvisomant. The name says it is somatotropin. Somatotropin means growth hormone antagonist. Somatotropin antagonist used for acromegaly. Another drug which can be used in acromegaly is bromocriptine or cabergoline. And important to remember, these are the only drugs which can be given orally for acromegaly. Other drugs are injectable. These can be given orally for acromegaly. Okay, so these are the important points regarding growth hormone inhibiting hormone. Then second important hormone is gonadotropin releasing hormone. Gonadotropin releasing hormone, if we give in continuous manner or if we give in pulsatile manner, the effects are different. Physiologically, it is secreted in pulses. So if we give in pulsatile manner, it will increase gonadotropin, and that will increase sex hormones like estrogen, progesterone, and testosterone. But if we give it continuously, or we can say non-pulsatile manner, then the action is reversed. So it will start decreasing gonadotropin, that can decrease these sex hormones. So that means we can use this hormone both to increase sex hormone as well as to decrease sex hormone. So when we want to increase sex hormones, as in conditions of delayed puberty, we want to increase sex hormones. Hypogonadism, we want to increase sex hormones. Infertility and ovulatory infertility, we want to increase sex hormones. Undescendant testes, we want to increase sex hormones. So we can use this in pulsatile manner. But when we want to decrease sex hormones, like in case of carcinoma prostate, we want to decrease testosterone. In case of endometriosis, we want to decrease estrogen. So whenever we want precocious puberty, we want to decrease sex hormones. So whenever we want to decrease sex hormones, we will give them non-pulsatile or continuous manner. Okay. Now coming to the drugs which are called GnRH agonists. The first drug in this group was leuprolide, and other drugs which are present in this group, their name end with relin, like nafarelin, gozerelin, buzurelin, histarelin. The name end with relin. They are GnRH agonists. If they are given continuously, they decrease sex hormones. When they are given pulsatile, they increase sex hormones. But all of them are injectable drugs. None of them is effective orally. But problem is, when we want to decrease sex hormones, still they will increase for some days. So initial increase will aggravate the symptoms, that is known as flare up reaction. So if we do not want this flare up reaction, we will use antagonist, because antagonist will decrease right from the beginning. And what are GnRH antagonists? The drugs which are GnRH antagonists, their name end with relix. Remember, relin end with agonist, relix end with antagonist, X means cross. The drugs like cetrorelix, ganirelix, abarelix, dagarelix, these are GnRH antagonists. They do not cause flare up reaction, but the disadvantage is they only decrease sex hormones. They are used only to decrease sex hormones. That means in conditions like endometriosis or in conditions like precocious puberty, carcinoma prostate, but they cannot be used to increase sex hormones. Okay? Now these are also injectable drugs. They are not effective orally. Now recently we have developed a drug called as elagolix. This is the only GnRH antagonist which can be given orally, and it's mainly used for endometriosis. So the name says lix, like other relix, it is ending with the lix, so it is GnRH antagonist and it is given orally. So it is a GnRH antagonist which can be given orally. Then it is used for treatment of endometriosis. Okay, so that is about the gonadotropin releasing hormone. Then the third important hormone in the anterior pituitary is prolactin inhibiting hormone, and this is nothing but dopamine. So that means when we stimulate the dopamine receptors, we will decrease prolactin, and the drug which stimulate dopamine receptors are bromocriptine and cabergoline like drugs. They can be given orally, and they are drug of choice for hyperprolactinemia. Remember, if there is prolactin secreting tumor in the pituitary, then first we can try to manage with the drugs, but definitive treatment obviously is surgery. If the patient do not want surgery, we can give bromocriptine like drugs to treat hyperprolactinemia. So they can be used for treatment of galactorrhea also, infertility due to hyperprolactinemia. So remember, only when it is due to hyperprolactinemia we can use them. Okay, so that is about the anterior pituitary. Now the posterior pituitary, it secretes two main hormones, that is oxytocin and vasopressin. Oxytocin, it has two important uses. One, it is a milk ejecting hormone. So it can be used when we want to eject the milk, as in case of breast engorgement. And second, it will uterotonic, it stimulate the uterus. Oxytocin drug or stimulate the uterus, and this action, it is used as drug of choice for induction of labor. So whenever we want to improve labor pains, we want to increase contractility, we use oxytocin. And second, oxytocin is also drug of choice for postpartum hemorrhage. So when there is bleeding, we will contract the uterus. It is drug of choice for postpartum hemorrhage. Now one of the oxytocin derivative, which is called as carbetocin, it is also used in postpartum hemorrhage. And the dose of carbetocin is sometime asked. The dose of carbetocin is 100 microgram intravenously over 1 minute. So remember, it is everything one in the name. So you can say it is saying it is used for postpartum hemorrhage. That means the delivery has been done. So जब डिलीवरी हो गई तो बच्चे को घर लेके जाना है, तो कार भी तो चाहिए. तो नेम इज सेइंग कार भी तो चाहिए. और कितनी कार चाहिए बच्चे के लिए? एक ही तो कार चाहिए होगी. सो एक मीन्स 100 माइक्रोग्राम, एक मीन्स लुक लाइक 1 IV, एंड एक मीन it is given in 1 minute. Okay? So 100 microgram IV over 1 minute, carbetocin. Then coming to vasopressin. Vasopressin work on two type of receptors, V1 and V2. The other name of vasopressin is ADH, antidiuretic hormone. V1 receptor cause vasoconstriction, whereas V2 receptor it decrease one urine, and second it cause a release of von Willebrand factor and factor 8 from the endothelium. Okay, so because of vasoconstriction we can use V1 receptor for treatment of esophageal varices. The drug we use is terlipressin. Terlipressin, it stimulates V1 receptor used for esophageal varices, whereas the drug stimulating V2 receptor is desmopressin. And desmopressin decrease urine, so it is a drug of choice for nocturnal enuresis as well as drug of choice for diabetes insipidus. Mainly neurogenic diabetes insipidus, it is a drug of choice. Then it can also be used for treatment of von Willebrand disease and hemophilia. We can use desmopressin. Okay. Then coming to ADH antagonist or vasopressin antagonist. Vasopressin antagonist, the name end with Vaptan. Vaptan says vasopressin antagonist. And the drugs like conivaptan and tolvaptan, they are vasopressin antagonists, and they are drugs which can be used in SIADH, syndrome of inappropriate ADH secretion. Okay. So that is about the pituitary hormones. Coming to the next endocrine gland, which is thyroid. There are two type of problems in the thyroid. One is hyperthyroidism, and second is hypothyroidism. Now, if there is hypothyroidism, there is simply replacement use. So we can replace the thyroid hormone. We can give T3 or we can give T4. The drug which is T3 is liothyronine, whereas drug which is T4 is L-thyroxine, which is long acting, and L-thyroxine is a drug of choice for every case of hypothyroidism. L-thyroxine is started at a dose of around 25 microgram daily, and gradually the dose should be increased. Okay. Then coming to hyperthyroidism. In hyperthyroidism, we want to decrease thyroid hormones, and we have several drugs which can decrease thyroid hormones. And for decreasing thyroid hormone, we can use the most important drug, which are known as thyroid peroxidase inhibitors. Thyroid peroxidase is the main enzyme which help in formation of thyroid hormone, and we have three drugs which inhibit thyroid peroxidase. One is carbimazole, second is methimazole, and third is propyl thiouracil. And the difference between the two is important. Carbimazole and methimazole, they are more potent drugs, whereas propyl thiouracil is having less potency. Second, propyl thiouracil crosses the placenta less transfer across placenta, whereas these have more transfer across placenta. So due to this reason, propyl thiouracil, it is a drug of choice in first trimester of pregnancy, whereas for all other cases we prefer carbimazole because they are longer acting drugs also. They have more plasma half-life, they are longer acting, so they are drug of choice for every case except in first trimester when we prefer propyl thiouracil. The name says पहले trimester में use करना है, PTU. Others, for every other case we use carbimazole like drugs. Now all these drugs, the side effect is agranulocytosis. All antithyroid drugs can cause agranulocytosis, and if we give in pregnancy, particularly carbimazole like drugs, they can cause fetal abnormality like choanal atresia. Okay. Then second group of drugs for hyperthyroidism are iodide like sodium and potassium iodide or Lugol's iodine. These drugs, they are fastest acting antithyroid drugs. Fastest acting, they are mainly used before surgery so that the thyroid gland shrinks in size and we can do the surgery easily. Then third group of drugs, these are radioactive iodine or iodine 131. Now because of radioactivity, it is contraindicated in pregnancy. Problem is another problem, it causes irreversible hypothyroidism. All other drugs cause reversible, it causes irreversible hypothyroidism. It is contraindicated in young patients, particularly less than 35 years of age. The problems with the radioactive iodine, and route of administration is oral, it can be given orally. Okay. Then we have drugs where for symptomatic relief like beta blockers. Beta blockers, they are drugs used for symptomatic relief in emergency cases. When there is severe hypothyroidism, beta blockers are drug of choice. Drug of choice for emergency hyperthyroidism, known as thyroid storm. Thyroid storm, beta blockers are drug of choice. Apart from beta blocker, we can use other drugs like propyl thiouracil in thyroid storm. Okay. So these are the important points regarding the anti-thyroid drugs. Next endocrine gland is pancreas. Pancreas, the main hormones are insulin and glucagon. Glucagon increase blood sugar, so used for hypoglycemia. But it is not effective in hypoglycemia due to starvation or hypoglycemia due to alcoholism. Apart from hypoglycemia, it is drug of choice for beta blocker poisoning. Glucagon is drug of choice for beta blocker poisoning. Coming to main hormone, insulin. Insulin, it comes in various preparations like short acting insulins, intermediate acting insulins, and long acting insulins. Short acting insulins like regular insulin, intermediate acting like NPH insulins, and then we have semi lente, which is short acting, lente, which is intermediate, and ultra lente, which is long acting insulins. All the insulins, they can be given subcutaneously. Then we have new insulins, which are called as insulin analogs. They have slight modification in the structure, but function is same. The insulins like insulin lispro, insulin aspart, and insulin glulysin. These are ultra rapid acting insulin. Where we have ultra long acting insulins also, like insulin datamir. We have long acting insulins like insulin datamir and insulin d-glutac. These are ultra long acting insulin. Now, insulins all are given by subcutaneous route except regular insulin, which can be given subcutaneously, obviously, like all, as well as intravenously. So it is insulin of choice in diabetic ketoacidosis. So in diabetic ketoacidosis, in fact, you need to remember that drug of choice is not only insulin. Obviously, insulin has to be used, regular insulin has to be used, but apart from that, we have to use intravenous fluid. Both of them are must. Okay. So regular insulin can be given IV also. Now, insulin, it is a drug of choice for diabetes mellitus. Both type 1 diabetes, it is drug of choice, obviously, and type 2 uncontrolled patient is drug of choice. Apart from diabetes, it is drug of choice for gestational diabetes or diabetes in pregnancy diabetes. Then insulin is also used for treatment of hyperkalemia. It result in movement of potassium inside the cells, so there will be treatment of hyperkalemia. The main side effect of insulin is hypoglycemia. Hypoglycemia is the major adverse effect of insulin. Okay. Now, apart from insulin, there are some other drugs which can be used in diabetes, preferably oral drugs, oral anti-diabetic drugs. And oral anti-diabetic drugs we can divide in two categories. One which act by secreting insulin, called as insulin secretagogues, and second which act by some other mechanism. The drugs which are insulin secretagogues, they include drugs like sulfonylureas, like we have first generation chlorpropamide and tolbutamide, and we have second generation drugs like glipizide, gliclazide, glibenclamide, the drugs whose name start with gli. Then the second group of drugs are meglitinide group of drugs, meglitinides, the drugs like nataglinide and repaglinide. The common thing among all these drugs is these drugs secrete insulin. Because they are secreting insulin, so they can cause same side effect which insulin causes, that is hypoglycemia. So these are the anti-diabetic drugs which can cause hypoglycemia, and you can find that all these drugs, their name end with ide. So if a drug's name end with ide, it will cause hypoglycemia. The drugs whose name end with ide will cause hypoglycemia. Okay. Now, then the drugs which act by other mechanisms. These include metformin and fenformin group of drugs. The very important point about metformin to remember, metformin, it is a drug of choice for type 2 diabetes, type 2 diabetes mellitus. The reason, metformin, it is having maximum reduction in HbA1c level. So most effective anti-diabetic drug. Second, it is very safe drug, usually do not cause much side effects. The major side effect of it is megaloblastic anemia. Otherwise it is very safe. Another advantage, do not cause hypoglycemia, no risk of hypoglycemia. Third, it can cause weight loss or no change in weight. Remember, it do not cause weight gain. Sulfonylureas cause weight gain, it do not cause weight gain. So because of all these advantages, it is first line drug for type 2 diabetes mellitus. Now, metformin group of drugs can cause lactic acidosis. Although it is uncommon, but sometimes it can occur. So these drugs are contraindicated in conditions where there is increased risk of lactic acidosis. So the risk of lactic acidosis increases in patient with liver or kidney disease. So if the patient has liver or kidney disease, there is risk of lactic acidosis when we give metformin. Okay, so it is contraindicated. Then second group of drugs are known as PPAR gamma agonists. Their name end with glitazones. Glitazones like rosiglitazone, troglitazone, and pioglitazone. Glitazones, they in reverse insulin resistance, we can say they reverse insulin resistance. Now, glitazones have one important problem, that long term of use, they have been associated with increased risk of fractures. There is increased risk of fractures with the use of glitazones. Now, glitazones, troglitazone has been withdrawn now because it was hepatotoxic, highly hepatotoxic. Other glitazones can also cause hepatotoxicity. Rosiglitazone increased the risk of myocardial infarction, whereas pioglitazone increased the risk of urinary bladder carcinoma. So that is about glitazones. Then the third group of drugs are alpha glucosidase inhibitors like acarbose and miglito. So these inhibit the intestinal absorption of carbohydrates. The main problem is these result in retention of carbohydrate in the GIT, which can be utilized by bacteria, leading to fermentation. Lot of gases are produced. So these are contraindicated in conditions like inflammatory bowel disease because the intestine may rupture. And second, if the hypoglycemia occur while taking these drugs, per se they do not cause hypoglycemia, but if hypoglycemia occur while taking these drugs, we should use glucose because food cannot be broken. Okay. Then some of the new drugs in anti-diabetic category, new anti-diabetic drugs. The main target in the new drugs is an incretin known as glucagon-like peptide. Glucagon-like peptide normally result in secretion of insulin when we take food. So after production, GLP is metabolized. It is broken down by an enzyme called as DPP4. So GLP release insulin. So we can give GLP from outside, or we can give a drug which inhibit the metabolism of GLP. The drug which is GLP given from outside, these include drugs like exenatide, liraglutide, semaglutide. So drugs which end with glutide, teduglutide. So all these drugs are GLP analogs. Among these, the other drugs, they are GLP-1 analogs. Whereas teduglutide, the name says it is GLP-2 analog. Okay. So all these drugs are used in diabetes, but teduglutide, it is mainly used for short bowel syndrome. Short bowel syndrome. Okay. And as the name says, their name end with the tide means these are not effective orally because they are peptides, so they need to be given subcutaneously. These are given subcutaneously, and their major side effect being nausea. And apart from nausea, they increase the risk of medullary carcinoma of thyroid. Okay. Then DPP4 inhibitors, they can be given orally. DPP4 inhibitors can be given orally. Their name end with gliptin like sitagliptin, vildagliptin, linagliptin, allogliptin. So many drugs whose name end with the gliptin, they are DPP4 inhibitors. The most important thing, they can cause nasopharyngitis as a side effect. Apart from this, they can cause acute pancreatitis. They are associated with pancreatitis, and gliptins are avoided in renal failure. They are contraindicated in renal failure. Only drug which is safe is linagliptin. So you can say in Hindi, linagliptin, the name says कि अगर किडनी फेल होगी तो भी लेना है, इसलिए इसको linagliptin कहते हैं. Linagliptin is safe in renal failure. Okay, so this is the first new strategy in diabetes. Then second new strategy in diabetes is SGLT2 inhibitors. So in the proximal tubules of the kidney, there is presence of a pump known as sodium glucose transporter 2. Sodium glucose transporter 2, so which help in reabsorption of sodium and glucose. So when glucose is filtered, almost 100% is reabsorbed. So if we inhibit this, then glucose cannot be reabsorbed, so it will be excreted in the urine. So these drugs act by causing glucose urea. So their mechanism is they inhibit the reabsorption of glucose, so glucose is excreted in the urine, decrease in the blood. So these drugs, they mainly act by causing excretion of glucose, and the drugs in this group are named and with gliflozin, like canagliflozin, dapagliflozin, ertugliflozin, empagliflozin. The name end with gliflozin, and from the name you can remember, just end urine at the end. So glucose flows in urine. That is the mechanism. So when the glucose flows in the urine, the bacteria will also reach the urine to eat that. So the most common side effect of gluclozin is urinary tract infections. So these can result in UTIs, even syndrome like Fournier's gangrene. Urogenital infections are the common. Urosepsis is another thing that can happen. That is the important. Second important thing, these drugs, if given in type 1 diabetes mellitus, they will decrease blood sugar. So the person may stop taking insulin, and if the person do not take insulin, that can result in diabetic ketoacidosis. They increase the risk of diabetic ketoacidosis because the person may stop taking insulin. Okay. Then the third drug which can be used in diabetes acting by this mechanism, new mechanism, is pramlintide. Pramlintide is a new drug which is a myelin analog. It work like a myelin analog. It is also tide, means it is not effective orally, peptide drug. And special point about pramlintide, it is the only drug which is used in type 1 diabetes as well as type 2 diabetes apart from insulin. So insulin and pramlintide are the only two drugs which are used in both type 1 as well as type 2 diabetes. Okay. And lastly, there is another drug which is called as bromocriptine. Yes, it is the same drug which we discussed in hyperprolactinemia. It has also been approved in type 2 diabetes mellitus. It decreases insulin resistance. Okay. The next endocrine gland is adrenal. So the main is adrenal cortex, which secrete glucocorticoids and mineralocorticoids. The special point about them, first of all, glucocorticoids may be short acting, intermediate acting, and long acting. Short acting glucocorticoids like cortisone and hydrocortisone. Intermediate acting like prednisolone and triamcinolone. And long acting, their name end with methasone like betamethasone, dexamethasone, paramethasone. Whereas mineralocorticoids, which cause retention of sodium and water, these include aldosterone, fludrocortisone. The important MCQs which are asked from these drugs, drug with maximum glucocorticoid activity is dexamethasone. The name says 10 guna, dexa. Maximum mineralocorticoid we all know is aldosterone. Then glucocorticoid with maximum mineralocorticoid active is hydrocortisone. Glucocorticoid with maximum mineralocorticoid, because hydro says water retain. Then mineralocorticoid with maximum glucocorticoid activity is fludrocortisone. Mineralocorticoid with maximum glucocorticoid activity. So the name says fluid retaining drug with cortisone like activity. Then drug with zero glucocorticoid activity, zero mineralocorticoid activity first. The drug having zero means O and M in the name. So lower four drugs, triamcinolone, dexabetaparamethasone, they have O and M in the name. O and M in the name. Whereas drug with zero glucocorticoid activity, which do not have any glucocorticoid activity, is DOCA. The DOCA name says drug with zero cortisone like activity. Okay. Now coming to important uses of these drugs. These have very strong anti-inflammatory uses, used for plenty of conditions ending with itis. They are very strong immunosuppressant. They can be used in conditions like autoimmune diseases and for transplantations. Apart from that, these are users replacement when endogenous glucocorticoids are less, like adrenal insufficiency, they can be used. Now, what is important is their use, which is non-replacement use, known as antenatal use. So they are used for fetal lung maturation. Glucocorticoid used for fetal lung maturation. We can use betamethasone or we can use dexamethasone. The doses are important. Betamethasone, the dose is 12 milligram. 12 milligram dose. Both are given intramuscularly, whereas the dose of dexamethasone is 6 milligram. So it is given 24 hourly. That means one dose is now, one after 24 hours, and total 2 doses. Whereas it is given 12 hourly. That means after every 12 hour we will give dose, and total 4 doses. Okay. So you can remember this. Beta means B means second letter, so it is given 2 doses. Dexa means D means fourth letter, 4 doses. So total dose we have to make 24. So 2 doses 12 milligram each, 4 doses 6 milligram each, and total duration make it 48. So 2 into 24 48, 4 into 12 40. Okay, so that is antenatal use of glucocorticoids. The main problem in glucocorticoids, or we can say side effects of glucocorticoids. So you can remember from the mnemonic glucocorticoids, the main side effects you can remember from glucocorticoids. So glaucoma, glucocorticoid eye drops lead to glaucoma, limb muscle atrophy. So basically long-term use can cause muscle atrophies, ulcer, peptic ulcer can occur, cataract. Remember, oral use will cause cataract, local use will cause glaucoma, osteoporosis. Long-term use of glucocorticoids is associated with osteoporosis. Then Cushing syndrome. We know glucocorticoid excess can result in Cushing syndrome. Osteonecrosis can occur when we use in high doses. Then they are contraindicated in renal failure and in case of TB, particularly ileocecal tuberculosis. They are absolutely contraindicated. These are contraindications. Then I for infections. Glucocorticoids are immunosuppressant and increase the risk of infections, particularly in the COVID times. That infection was, what is that infection? Mucormycosis. Then they are contraindicated in CHF and conditions with edema. They impair healing. Healing is impaired. Then they increase risk of diabetes mellitus by causing hyperglycemia, and they can cause suppression of HPA axis. So that is very important. Glucocorticoids can cause HPA axis suppression. So we need to prevent that. What are the options? How to prevent HPA axis suppression? The most important thing, do not use glucocorticoid unnecessarily. That means avoid when we can manage with other drugs. Suppose we cannot manage, we have to give the drug, then HPA axis suppression will occur when we give them continuously for around 2 weeks. So try to give them for less than 2 weeks. If we give them for 2, 3, 4 days only, HPA axis suppression will not occur. Suppose giving for more than 2 weeks is necessary, then try to give on alternate day. Alternate day therapy is required, so that one day body produce, another day we are giving from outside. Suppose alternate day therapy is also not possible, then gradually taper, because now HPA axis suppression will occur, so we need to gradually taper them. Okay, so that is how to prevent HPA axis suppression with glucocorticoids. So that is important about the adrenal gland. Then drugs and hormones affecting calcium balance. So 3 main drugs and hormones we have: vitamin D, calcitonin, and parathyroid hormone. So what is effect on serum calcium and serum phosphate? We all know vitamin D increase both in the blood, whereas calcitonin decrease both in the blood. Parathyroid increase in the calcium in the blood but decrease phosphate. So if we remain a discussion on the calcium, vitamin D increase calcium, whereas calcitonin decrease calcium, but both are used in osteoporosis because vitamin D increase calcium by increasing the absorption and decreasing excretion from the kidney, whereas calcitonin, it increase the movement of calcium from the blood to the bone. So when more goes to bone, we can treat osteoporosis. On the other hand, PTH will cause osteoporosis by increasing resorption of bones. Okay, in the blood it will increase, but in the bone it will decrease. Now the drugs which are used in osteoporosis, obviously we can use calcium. In osteoporosis, sometimes we need to give very high doses like 1200 milligram per day also. Along with calcium, we usually add vitamin D also. Then we can use thiazides. Remember, thiazide loop loses calcium, thyroid retain calcium. The most important drug which is used in osteoporosis is bisphosphonates. The name end with the dronate, like alendronate, risedronate, zolendronate. Dronates or bisphosphonates are drug of choice for osteoporosis. They act by inhibiting the osteoclast. So bone resorption will not occur. They can be used to treat osteoporosis. They can be used for several years. Usually we continue them for 5 years, and sometimes we can stop after 5 years, and we may continue them up to 10 years. So they can be given up to 10 years. Okay. Now alendronate and risedronate are given orally, whereas zolendronate is given IV once yearly. One IV infusion is given in an year. Now, oral bisphosphonate, the main precaution is they can cause esophageal ulcers. The main side effect is esophageal ulcers. So, we need to protect the person. So, 3 important precautions: always take empty stomach. Second, with full glass of water to dilute them. And third, do not lie down for minimum half an hour after taking the drug. These all are to prevent esophageal ulcers due to regurgitation. Okay. Now, bisphosphonate, which is zolendronate, that is given IV, has the side effect of causing renal failure. Zolendronate can cause a renal failure. Bisphosphonates are drug of choice for every type of osteoporosis, even post-menopausal osteoporosis. Then second important group of drug we can use in osteoporosis is SERMs, selective estrogen receptor modulators, like raloxifene. So if we see, SERMs are the drugs which have agonistic action on estrogen receptor at some places and antagonistic at some other places. So if we talk about the main places, we have bone, blood, breast, endometrium, and liver. The best SERM, or we can say best drug which act on them, is we want agonist on the bone so that the bone formation occur. We want agonist on the blood so that HDL increases. But we want antagonist in the breast, endometrium, and liver, because estrogen increases the risk of breast and endometrial cancer, and it causes thromboembolism in the liver. So raloxifene has all 4 advantages. That means it is agonist on the bone, blood, antagonist on the breast, endometrium. All these things we want, but it is agonist on the liver. So the major side effect of raloxifene is thromboembolism. The main side effect is thromboembolism. Okay. Then we have another new drug in osteoporosis, which is called as teriparatide, and a new drug called as abaloparatide. So as the name says, these are parat, means parathyroid hormones. These are PTH 1 to 34. These drugs act by stimulating osteoblast. Other drugs till now we have discussed are inhibiting osteoclast. It is stimulating osteoblast, but important thing is these are recommended for maximum 2 years. So after that we have to use bisphosphonates, or we can use other drugs, but they cannot be given for more than 2 years. They theoretically increase the risk of osteosarcoma. And they are not effective orally. They are given by a subcutaneous route. Teriparatide and abaloparatide. Then we have drug called as strontium ranelate. This is a drug which has a dual action. It stimulates osteoblast also and inhibit osteoclast also. And a new drug with the same category which has a dual action of stimulating blast and inhibiting clast, it is romosozumab. As the name says, it is a monoclonal antibody used in osteoporosis. Romosozumab is a monoclonal antibody against a protein known as sclerostin. And it also has dual action. That means romosozumab inhibit osteoclast and stimulate osteoblast. So 2 drugs having dual action. Then we have one more monoclonal antibody called as denosumab. This is monoclonal antibody against rank ligand. Monoclonal antibody against rank ligand is denosumab, and denosumab also acts by inhibiting osteoclast. So these are the important drugs used in osteoporosis. Then we have some sex hormones, particularly testosterone. If we see, testosterone it is metabolized to dihydrotestosterone by an enzyme called as 5-alpha reductase. Dihydrotestosterone stimulate the androgen receptors that will cause male actions. Now, the important male actions, if you see, this androgen receptor whenever stimulated, this can result in alopecia, male pattern baldness. It can result in prostate cancer. So, if we inhibit this pathway, we can treat alopecia and prostate cancer. Now, what is important is testosterone increase DHT which stimulate androgen receptor, but androgen receptors can also be stimulated by testosterone directly. So we have two type of drugs, one which inhibit 5-alpha reductase and second directly block androgen receptors. The drug which block androgen receptors will be more effective because neither testosterone nor DHT will work, and these drugs include drugs like flutamide or any drug ending with lutamide, nilutamide, bicalutamide, enzalutamide. So any drug which end with lutamide is androgen receptor antagonist, and these are indicated in prostate cancer. Whereas 5-alpha reductase inhibitor like finasteride and dutasteride, these are the drugs which inhibit 5-alpha reductase. They decrease DHT but not testosterone. So they are used in treatment of alopecia, finasteride and dutasteride. And another use, they can be used in the benign conditions of prostate like benign prostatic hyperplasia, BPH or BHP. They are used in treatment of BPH or BHP. But important thing, in BPH or BHP, they take time. They will take several time because prostate has already grown, so they will take long time, few months to decrease its size. And apart from decreasing the size of prostate, they will also decrease the prostate specific antigen. As we discussed, they are inhibiting this pathway, so they will decrease dihydrotestosterone also. Okay, so these are important points regarding the testosterone, drugs acting on testosterone. Then the last thing is oral contraceptive pills. So oral contraceptive pills, they can be used as a combination of estrogen plus progesterone, which is known as combined oral contraceptive pill. They are given for 21 days and then there is 7 days gap because the tablet do not contain steroids in that. Now, the adverse effect of oral contraceptive pills, they can be divided into mild, moderate and severe. Mild side effects usually occur, so we say they are normal. Mild side effects तो होते ही normal. So these include nausea, edema, recurrent headaches, mastalgia, abnormal bleeding, which is called as breakthrough bleeding, and loss of withdrawal bleeding, that normal menstrual bleeding do not occur. Whereas moderate side effects are mostly cosmetic. These include acne, chloasma, and weight gain. Whereas severe side effects, you can remember them with 4 C's. Cardiovascular side effects, particularly increased risk of thromboembolism, myocardial infarction, stroke, DVT, all of them. CNS side effects like depression, they can unmask the depression. Then cholestasis, they can cause cholestatic jaundice. And lastly, cancers. OCPs, they increase the risk of cervical and breast cancer. Breast cancer mainly with those OCP which has high dose estrogen, but they can decrease the risk of certain cancers, like they can decrease the endometrial and ovarian cancer. Okay? So if you divide the body from the diaphragm in 2 parts, upper cancers go up, lower cancer go low. So upper cancers above the diaphragm, we have breast, so breast cancer goes up. We have cervical, obviously we are not talking about this, we are talking about cervix. So just to remember, cervical cancer, they go up, whereas the lower cancers like endometrium and ovarian cancer, they will go down. So apart from combined oral contraceptive pills, we have some emergency contraceptives. So emergency contraceptive pills, they can be combined oral contraceptive pills given in double dose. They can be progesterone only pills like levonorgestrone, and there is a drug called as mifepristone, which is selective progesterone receptor antagonist. All these need to be given within 72 hours of unprotected intercourse. Then we have another drug called as ulipristal, which is given as a 30 milligram tablet. It can be given up to 5 days of the unprotected intercourse. That means up to 120 hours of unprotected intercourse. So these are the emergency contraceptives. Then lastly, we have a group of drugs called as aromatase inhibitors. Aromatase inhibitors. Normally, aromatase convert the androgen to estrogens. In postmenopausal female, aromatase is the one which is mainly producing estrogen. So in simple language, if we inhibit the aromatase enzyme, there will be decrease in estrogens. And the aromatase inhibitors, the drugs include letrozole, anastrozole, exemestane. So these drugs decrease estrogen, so they can be used in postmenopausal breast carcinoma. They can be used in postmenopausal breast carcinoma. And letrozole is a drug which is also used as ovulation inducer. Like clomiphene, it can be used as ovulation inducer. In fact, it is the preferred drug for ovulation inducer in PCOD nowadays. And the half-life of letrozole is around 45 hours. So these are the important points regarding the endocrine system.